Good morning, everybody. Welcome to the second edition of the continuation of the CME program on the occasion of a Just Look Foundation Day. Welcome everyone and all the galaxy of the speakers and our chairperson and CEO. As you know, Just Look has had 47 glorious years of high level of patient care, a lifetime care, and high level of personal care. And we are celebrating our Just Look Foundation Day. And we had our first seminar almost a month ago. And as usually, we have a theme of debates on the CMEs, but this time looking at the crisis of the COVID and the way the problems which everybody across the world has faced and we faced, and we have come out successfully fighting and completely reigning over it. Therefore, we changed the theme of our CME to the how to manage the patients in COVID-19 era. And we have galaxy of speakers here, and we are very fortunate to have our chairperson, Mrs. Kantama San, with us to address this meeting. She is our great support and always interested in supporting all such kind of the CMEs. Can I request Mrs. Kantama San, our chairperson, to give her address, please?
Good morning, everyone. Welcome to Just Look Hospital's webinar on how to manage patients in the COVID-19 era. I know that all of you have many personal constraints and challenges during the COVID era, and I would like to start by sincerely thanking you for your presence here on this Sunday morning. I would like to wish you all a belated Happy Independence Day. Hope and pray that this year brings us peace, progress, and above all, a swift resolution to the pandemic. As you all know, since its inception 47 years ago, Just Look Hospital has been dedicated towards patient care, comfort, and well-being. The bedrock of our mission has been our eminent doctors who have always been right at the very forefront of medical research, knowledge, and technology. On Founders Day every year, we therefore hold a medical conference for continuing education. Due to the roaring success of the last one, we have decided to have 2 more this year. In the second session, we are privileged to have among us the leading doctors of India, sharing their experience, their knowledge, and experience in treating patients in this time of pandemic. Moderating this webinar, we have Dr. Sarosh Katrak and Dr. Shrinivas Desai. Dr. Katrak, I would like to thank you for the monumental job you have done in moderating these medical sessions all these years. With a heavy heart, I would like to inform everyone that Dr. Katrak will not be part of these programs in the future. We cannot thank you enough for your contribution towards setting many a milestone in the history of Just Look. Dr. Katrak, we are forever indebted. I'd like to end by saying that we are currently facing a financial situation that is unprecedented in our lifetime. The role of scientific knowledge in treating this novel coronavirus is paramount for us in the hospital. I therefore regard this session as critical to our mission and wish you all a successful, educative morning. Thank you all.
Thank you, Kanta, very much for those very kind, encouraging words and very apt words. Can I request our CEO, young dynamic CEO, Mr. Jitendra Harian, to share his thoughts, please?
Thank you, ma'am. Good morning and a warm welcome to all the participants to the part 2 of CME on how to manage patients. Thank you for the overwhelming response to the last CME, which inspired us to do the part 2 of it and cover other specialties. We are in the times where COVID has become a harsh reality of life. It means providing safety to the non-COVID patient becomes utmost critical. At Just Look, therefore, we have laid down robust protocols to ensure that the non-COVID patients are at no risk when they walk into the hospital. We have practiced these protocols over the last 4 months, and we have received encouraging feedback from the patients and their relatives that they felt safe and confident during their stay. We have made divisions of the hospital areas into green, orange, and red which are in association with the COVID infection risk involved. This makes it easier for the staff and patients to follow protocols without any ambiguity and gives them a good amount of confidence. We have almost started all non-COVID work, including transplants, and I'm glad to share that a single tested and confirmed non-COVID patient got COVID infection while he was discharged. That motivated us to share our learnings through the CME platform. I wish best of luck to all the speakers and hope that this program adds to your learning. Thank you.
Thank you, sir. Thank you very much. Your talk is instilling the confidence, because the whole idea of this meeting is to address the doubts in the minds of the medical community and the patients at large. And now, after this, we are shifting over
Good
to
morning,
the basic
everybody.
talks, and I will hand over the mic
And at
now
the very
to
outset, let me
Sarosh
wish all
Katrak
the PASI
for his
participants
introductory remarks,
a very
and then
happy
take
new
over
year.
for the speakers.
When I spoke on a webinar on 18th of July 2020, I mentioned that the COVID-19 pandemic had affected nearly 14 million people worldwide. In nearly 1 month's time, or little short of 1 month, the figure now stands at a little over 21 million, with over 14 million recoveries and 763,000 deaths. For India, the respective figures are 2.5 million affected, 1.8 million recovered, and fortunately a very low death rate of only 36 per million. And in today's paper, we have nearly over 50,000 deaths. This pandemic has also brought out in sharp focus the pathetic spending on healthcare. This spending as a percentage of the GDP has risen by only 0.3% from 2002, 2003 to 2019-20. And I hope that everybody has realized that healthcare is a very important part of our spending. In the first part of our webinar, we covered various aspects of ICU management and therapy, cardiology, psychology, imaging in COVID-19, and a special emphasis was given to dialysis and renal transplant in chronic kidney disease. In part 2, we are covering differential diagnosis of PUOs in the COVID era, diagnostic tests, pregnancies and IVF, aspects of surgery in orthopedics, GI surgery, oncosurgery, neurosurgery, strokes in the COVID era, and lastly, medico-legal aspects of COVID-19. As you can see, it is a full program, and therefore, without much ado, I will request Dr. Hemant Thacker, consultant physician at Jaslok Hospital, to begin his deliberations on are all fevers due to COVID-19 in this era. Over to Dr. Hemant Thacker.
So folks, yesterday was Saturday night. I don't know how many of you had Saturday night fever, but ever since the 23rd of March, the whole country, the whole world, the universe is stuck with fever. And fever only means one thing: COVID-19. Now that more than 3 to 4 months in our country and probably 8 months all over the world have elapsed, fever still poses an important question. And for every fever, there is a challenge, and you have to take COVID through the eye of a needle before really looking at everything. Unfortunately, what has happened is COVID has tinted everybody's glasses. In fact, it's a doctor's dilemma. every fever that comes is looked upon as COVID. If an orthopedic surgeon is called in for a fracture, he wants to know whether the patient had fever and then a fall. If a gynecologist is asked to come in, she wonders whether the spotting is because of COVID and fever. And the diverticulosis is still looked upon as COVID first and everything else later. In fact, common sense and common fevers have gone out of the thinking box, and everybody is looking at COVID, COVID, and only COVID. And the common sense thinking out of the COVID box of mundane routine things from malaria, dengue, non-specific viral infections. How many times have you and I have sore throat in this city? The pollution, the air change, the respiratory problems, all of that, and day-to-day infections. I'm afraid traditional thinking has gone with the wind. Today, the glasses which all of us are wearing have only COVID written on it. So I need to jog your memory. I need to bring you back into reality. We've all forgotten our medicine. Surgical housemen are doing COVID duties. Anesthetists are doing COVID duties. And everybody is only thinking of COVID-related issues. I'm so glad our CEO, Mr. Harian, said that we are almost back to doing a lot of non-COVID work in almost all non-COVID work. And that too, our patients are going back with no infection. COVID is a way of life. We were all scared and put in a corner and went into a huddle with H1N1. Where is H1N1 today? The same thing will happen one day with COVID, and it's that hope that I want to remind everybody and take them back to their traditional learning that fever has many other causes. And if I was to go and rewrite your memory, major causes, 2/3 of it is infection and 1/3 is miscellaneous. Infective causes can be general or can be specific. Common infections, abscesses. You know, we've had patients who come in with fever and loose motions. And everybody says, हाँ, loose motion to COVID में होता है, or fever है. This is COVID. What about that amoebic liver abscess, which the patient is shivering with? So you can get abscesses in the hepatobiliary, abdomen, pelvis. Upper respiratory and sinus infections are often forgotten. In fact, almost forgotten, either because the ENT wants remote control or the person looking at it in the casualty through a 3-layered mask and COVID glasses forgets that there are sinuses behind the cheeks and there is a eardrum which can get inflamed. The poor dentist who is in kiss distance of the patient has probably gone into oblivion. He doesn't want to touch the patient doesn't want to go there. So dental causes of infection giving rise to fever, which is the single most largest for prescribed illness in the world over, is dental issues and then hypertension. Eye opener that there are more dental problems than hypertensives in the world. Of course, the other infective causes which are there is infective endocarditis. And what about urinary tract infection? Women at all ages, premenopausal, postmenopausal, all of them have fever. Diabetics have non-specific urethritis with fever. The prostate plagues the aging man. So urinary tract infections. Infections can be bacterial. Let's look at typhoid. In the monsoon, leptospira. We've forgotten tubercle. At one stage, everything was tubercle unless proved otherwise. Rarer diseases like brucella and Lyme's disease. What about viral infections? Non-specific viral infections, we've forgotten. The flu with a host of different strains. Hepatitis, dengue, CMV, EBV, and of course, HIV. HIV is in the background of any and every fever infection, and that too has receded in the background. Malaria has made a strong comeback. This year, we are seeing a doubling or a tripling of malaria cases. In fact, last year, all of us had complimented the BMC for their anti-malaria campaign. I'm afraid the BMC's resources have been strained. I'm not blaming them. They're probably busy with other things. Amoebiasis, water contamination, amoebiasis, the loose motions, definitely. And of course, the other protozoal infections to cover the list is Leishmania, Toxoplasma, and trypanosomiasis. Not to forget that there are rarer typhus and Q fever, rickettsial diseases, and cetocosis. For those of you who's reading the Times of India, if you see yesterday, in Spain, they have detected 25 cases of West Nile fever. And in Kuala Lumpur, they have reported in Malaysia 59 dengue deaths. All this in COVID times. What about the non-infective causes of fever? Malignancy. About 20% of fevers is malignancy. First presentation. Patient comes to the casualty, has lost weight, is not eating too well, has fever, and you all blame it onto the lockdown, the neglect, didn't get his milk, didn't get his vegetables. But hematological, lymphoma, leukemia, myeloma being very common because there's body ache. Then of course you have the renal, liver, colon, stomach, and pancreas, which are solid tumors. It is the hematology. We've picked up in the last 4 months at least 5 myelomas and so many other hematological malignancies. Not to say that the solid tumors don't present as fever, but then they are also presenting with their other typical symptoms which come to the fore. What about autoimmune rheumatic disorders? Fibromyalgia, gout, infectious arthritis, juvenile idiopathic arthritis, collagen, lupus is forgotten. Everybody feels that the vague joint pains, a little bit of skin involvement, abdominal pain is psychological, functional, and of course osteoarthritis. There is a degeneration. People have nothing else to do, so either they eat and put on weight, or they walk and denude their joints and present with osteoarthritis. So rheumatic disorders and autoimmune other conditions. Then there is the miscellaneous, cardiovascular, respiratory, etc. In the cardiovascular, aortitis, aortic dissection, and rarely atrial myxoma. Respiratory, of course, tuberculosis, sarcoidosis, pneumonia of all varieties, organizing. Today, the CT scan job is very simple. You see anything and you write, in the given pandemic situation, COVID needs to be ruled out. But there are so many types. In common man, houseman's language, there are 1,000 causes for pneumonia, which are forgotten. Pulmonary embolism, thromboembolism, emphysema. Inflammatory bowel disease, especially the low-grade inflammatory disease, alcoholic liver disease, subclinical pancreatitis, subclinical appendicitis, granulomatous hepatitis. These are the gastrointestinal causes. Endocrine and metabolic, thyroid and thyroiditis with pain in the throat and a little bit of cough can be confused as fever of COVID origin. Adrenal insufficiencies, PHOS and hypertriglyceridemia. We've already mentioned the hematological, hemolytic anemias, the hemoglobin urias, and of course, graft versus host disease. There are certain inherited fevers to make the entire list complete. Mediterranean fever of familial variety and the periodic fever syndrome. Not to forget drug reactions. Too much of antibiotic, drug hypersensitivity, and that causes drug reactions and drug fever. If it's not all that, and if 3 weeks have gone by and fever persists with no clear diagnosis, despite intelligent and intensive investigation, even after listening to today's CME, which we have, if we still have PUO, it is then by definition PUO. Fever, ladies and gentlemen, is not a disease. Today, it's a symptom of the underlying illness which we have forgotten. Fever with patients these days are walking on a tightrope. Every patient comes, he doesn't want to come to hospital. He doesn't want to go to the clinic. He doesn't want to see the doctor. He's walking on a tightrope. He's scared that he's incubating COVID. When he comes to the casualty, the unknowing person is worried. So fever these days is not a diagnosis. It is a case of detection. And it is in these critical moments that this rope gets broken. Remember, in Greek, pyre meant fire, and in Latin, febrile is febris. So in Greek and Latin, it was pyrexia. But I again need to remind you, pyrexia today is not all COVID. Just because the watchman, the liftman, the entryman, and everywhere else you go is armed with a gun to diagnose. Which brings me to the biggest cause of fever today. We are doing so many teleconsultations every day. In fact, if you see my article in today's Times of India on telemedicine, the biggest symptom is, साहब वो thermometer पे 99.5 आता है, मैं डोलो दूं. Nobody gave a damn for 99.5. But overuse of the thermometer, we are treating more of the thermometer. The watchman detects fever. The doctor doesn't diagnose the condition. The entryman tells you, "Ye pe aapka theek nahi hai, go back." So fever is not a diagnosis. Today it has become, unfortunately, a detection. COVID has buried all other fevers. It has tainted your thinking. You have to look what lies beneath. You studied for a minimum of 5.5, and most of you for many, many years after that, and then you learned your medicine as you practiced. Don't forget that learning. Remember, the patient's life is in your hands. And if you think wisely, if you compartmentalize your knowledge into COVID in one corner, which will shrink and shrink. COVID was the whole horizon. Today, it has become 60% of the horizon. And we are all hoping that it becomes dimmer and it becomes receding in your horizon, especially with CMEs after this. We will be able to think of other things. Thank you. I hope I've kept my timing.
Next speaker is going to be Dr. Sudeshna Ray, who's a consultant obstetrician and gynecologist at Jaslok. And she is going to talk on pregnancies during COVID times, challenges faced by the mother and the fetus. Dr. Sudeshna Ray.
A very warm Sunday morning to all of you, to all my fellow colleagues and to all the doctors who are attending this session today. Thank you for spending a part of your precious Sunday with us. And the next few minutes, I'm going to talk about pregnancy in the COVID times. Interestingly, when I was going through the global literature regarding the influenza and pregnancy, I found out that the 1918 Spanish flu had a maternal mortality of 27%. When we are talking about H1N1, the maternal mortality was about 7 times higher than the non-H1N1 pregnancy. And when we are talking about COVID, the maternal mortality so far globally has been reported as 0.002%. And I thought this is one of the most positive notes that I will start my discussion with. Next slide, please. Yeah, next slide, please. Okay, so why talk about it? Why is pregnancy such an important topic for discussion, especially during the COVID times? Because one, pregnancy with its unique characteristic does not care about COVID at all. It doesn't bother what COVID gives. It will not change itself. So once pregnancy happens, the birth is inevitable. You cannot change it. You cannot stop it. You can postpone it. You cannot adjust with it. Pregnancy continues for about 9 months. So it's a long-term planning that needs, and it's very, very time specific. One of the most physiological events of life, yet there are so many physiological systemic changes that it makes a pregnancy a very, very vulnerable group to have any kind of infection. And most importantly, whenever we are dealing with pregnancy, we are dealing with 2 lives, both of which are extremely essential. So I'm going to cover whether pregnancy makes it a little different in COVID, whether the virus has any effect on the fetus, what is the global change in the antenatal care policy, what are the global changes in birthing policy, and of course, we're going to talk about just slow care. Next slide, please. So is COVID pregnancy any different? Well, whatever evidence we have so far, it says that there is no greater risk of seriously becoming unwell than any other adults. A large majority experience mild or moderate symptoms. There is an obstetric surveillance study from the UK which has been published in May 11th, and the CDC report from the US has been published on the June 20th, both of which have studied a lot of women, and they have said that most of the women who need admission, with pregnant women with COVID who needed admission, were just ward admissions, mostly ward admissions, and they were discharged healthy. There were some ICU admissions, but the percentage is small, and there were some deaths. However, they are not directly related to the COVID. The Blacks, Asians, and minority ethnic background have a higher risk of severe illness. Other factors which increase the risk of admission and serious illnesses are comorbidities like diabetes, high blood pressure, obesity, and age above 35. As I said before, that the absolute risk is substantially and significantly lower than the H1N1 pandemic in pregnancy. And most of the complications that we have seen is in the third trimester. So the prevention methods are overemphasized in the third trimester. Next, please. So any effect, does the virus have any effect on the fetus? Well, we have found that whatever evidence we have so far, there is no increased risk of miscarriage, no increased risk of fetal growth restriction. Whatever fetal growth restriction the pregnancy have shown is because of the obstetric factors and not directly related to COVID. There is a risk of vertical transmission, which means from the mother through the placenta to the unborn baby. However, the risk is found to be very small, and the good news is that whatever babies have been affected by the vertical risk, they have all done well, and the NICU admissions has not changed whether it's COVID or non-COVID mother. There is a higher risk of premature birth globally in Australia, in UK and US. Everywhere the risk of prematurity has increased. However, the prematurity concern cannot be directly again related to the COVID. It's too early to say that. And there is no risk of teratogenicity or any abnormality in the fetus because of the pregnancy. Can you go on to the next slide, please? Okay, so how are we adopting to the antenatal care? As you know that in a pregnancy, we need about 15 to 16 consultations throughout the pregnancy with the doctor. So here, along with the global scenario has also changed. We have also changed our model, and we are following a mixed model of teleconsulting and face-to-face appointments. So we are giving at least 6 face-to-face appointments, 1 in the first trimester, 1 in the second trimester, and 4 in the third trimester. If the pregnancy is critical, we are giving 3 more, 2 in the third trimester and 1 more in the second trimester. We are trying to combine essential tests and scans in a single appointment so that the patient does not have to run around hospitals and go to other labs and come back. So we need to combine them. And gone are the times when there is, the pregnant woman is accompanied by the mother, mother-in-law, sister, sister-in-law, everyone else. We are allowing only one person to visit during the antenatal appointments with the woman, with the pregnant women. And we are spacing out appointments so that we are avoiding crowding in the waiting area, 1. 2 is we have enough time for a good amount of screening, explaining PPE, and explaining the personal protection, and cleaning the rooms once one patient has gone. Then the room and the surfaces are completely clean before the next patient is brought in. So we're spacing the appointments for about 20 to 30 minutes in Just Look. Next, please. Okay, so the birthing policies, as we all know, the pregnancy is a very natural event of life, and we need a, we always expect a natural outcome. However, we have adopted this natural outcome a bit. In the US, the cesarean rates is almost 100% during the COVID times. However, in India, we are having a lot of normal deliveries, but we are following offering at least a policy of elective induction for the patient, so that the admissions are planned with a negative COVID report and a negative COVID screening. Otherwise, the patients land up in a suspect ward, which is not welcome to both the healthcare professionals as well as the patient and the family. We are all only allowing one partner during the birthing process. So the the partner stays throughout the whole stay of the woman with the woman and doesn't go home, doesn't go out of the hospital. It is found that epidural analgesia, epidural anesthesia, spinal anesthesia is completely safe even if the patient is COVID positive. We have to try to avoid any aerosol generating procedures such as general anesthesia and cesareans. But the water birth policy globally has been extremely restrictive. One, because we don't know the virus is getting transmitted in water or not. And second, the most important thing is whatever personal protection equipment we are using, they are not to be found so effective in water as they are when they are dry. Jaslok is a baby-friendly hospital, so we are encouraging rooming in and skin-to-skin contact policy because of its various benefits, and this is according with the World Health Organization. Even when we are suspecting COVID or when we are suspecting fever, as Dr. Hemant Thacker said, not all fevers are COVID, but we are still encouraging rooming in and skin-to-skin policy. Breastfeeding by WHO has been found to be extremely beneficial, and it overrides the small risk of COVID infection in the newborn, and hence it has to be encouraged, and we are following it strictly. A little bit about statistics. That's the only Indian study that has been given for publication. It has been accepted on the 5th of August. Nair Hospital has come up with a study of 400 women at a tertiary care, and it is said that it's possible to have a dedicated maternity services for safe pregnancy outcomes in COVID-19 settings. In the US, so far till August 11th, from January, the total cases has been over 16,000 with the hospital admission, almost 1/4 of it. And the total deaths is almost negligible. Again, these total deaths have been reported that they are not related to probably COVID and probably because of other obstetric indications. The Asian community has been, the hospital admissions have been very low. And even in the pregnancy, if you see the ICU admissions, the number of patients, number of COVID women, pregnant women needing mechanical ventilation is also low compared to the admission rates. So here what we are dealing with is not as dangerous as we are thinking about. So next, please. Yeah, so Jaslok has opened up doors to COVID since COVID has entered Mumbai. We have but we are proud to say that now out of the admissions, whatever we are having, 75% of these admissions are non-COVID admissions. And the Department of Obstetric and Gynecology, under the able guidance of Dr. G.N. Mansukhani, Dr. Firuza Parikh, have some eminent gynecologists like Dr. Danny, Dr. Anahata, Shilpa, Dr. Purnima. We have all together had about 68 pregnant admissions so far. We've been able to deliver 35 deliveries. We had 139 OPD consultation. We had opened up OPD about a month back. We had 73 online consultations, and I'm proud to say that with the infrastructure we have been successfully dealing with all complicated cases like preeclampsia, eclampsia, placental abrasion, cardiomyopathies in pregnancy. We had an obstetric hysterectomy once, and a lot of premature deliveries and twin pregnancies with challenges. Not only pregnancies, we are also doing general gynecology, like we have completely started off with our laparoscopic pelvic procedures and other gynac operations as well. Yeah. So looking forward towards a happy life, as we say that as Dr. Thacker says that it's going to go into the corner at once, but we have to deal with it for quite some time now. So let's adopt the new normal. Let's continue to safeguard ourselves. We have never thought of pregnancy being virtually cared, which we are doing now globally and here locally. And most importantly, let's not spread scare, let's spread a lot of positivity. Thank you so much for a patient hearing.
Thank you very much, Sudeshna, for clarifying many of the doubts that would be there in the lay public as well as doctors' minds.
Thank you.
And I think, thank you for giving the statistics closer to home, like in Mumbai from Nair Hospital, and also the Jaslok statistics. I think we now go on to the next speaker.
Thank you.
Thank you, Sudeshna. We now go on to the next speaker, who is Dr. Indraneel Raut, who is the Additional Director of Critical Care Medicine. And he is going to talk on the diagnostic tests for COVID-19, which one to do when. I think with the recent introduction of the rapid antigen test, I won't use the short form of rapid antigen test because it comes to RAT, which doesn't sound quite good. But with the recent introduction, there are a lot of doubts about which test to do and when to do the test. So over to Dr. Indraneel Raut.
Good morning, everyone. Thank you for the opportunity to being a part of this program. So let me start with my presentation. The coronaviruses are enveloped single-stranded RNA viruses. Nikhil, can't this go? I can't see this. It's a beta coronavirus, and it requires the ACE2 enzyme for the cell entry and also the TMP RSS2. The COVID-19 virus binds to the ACE2 inhibitor through the receptor binding region of its spike protein. This is a structural diagram which shows that the nucleocapsid protein is bound to the RNA genome to make up the nucleocapsid, spike protein which helps in binding to the host cell receptor. And
will you use your pointer to point out to the various structures?
Yeah. So this is the RNA, single-stranded RNA. This is a membrane protein which forms the gives a shape to the viruses. The nucleocapsid protein, which is bound to the RNA genome to make up the nucleocapsid, and this is the spike protein, or the which helps to bind to the receptor. So why to test? Firstly, to diagnose that you have COVID if the patient is symptomatic, and also to initiate the infection control measures so the disease will spread. And of course, it is required for, especially in the hospital settings, to segregate the patients into the non-COVID and the COVID areas and to prevent spread of the disease. What are the available tests? The NAT, antigen test, and the antibody test. What is NAT? Nucleic acid amplification test, there are two real-time RT-PCR, the TrueNAT and the CBNAT. Let's go to the NATs. And we'll start with the RT-PCR. RT-PCR is a reverse transcription polymerase chain reaction assay, which is most commonly used, and it is used as the initial diagnostic test for COVID-19 and probably considered as a gold standard. I'm saying probably because the sensitivity varies with different kits. So based on PCR, a process that repeatedly copies and amplifies the specific genetic fragments of the virus, ensuring that there is enough sample to conduct the analysis. This is a pictorial representation from the swab taken to the reverse transcriptase process and then the amplification of the virus. So the RT-PCR swab is collected from the nasopharynx or the oropharynx. We can even collect the lower respiratory samples in terms if the patient is on a ventilator for the tracheal or the PAL. swab contains only small quantity of RNA, which is not adequate. So the RNA, which is a single-stranded molecule, is then converted into double-stranded DNA using the reverse transcription. Then the primers are used, which are small pieces of the DNA designed only to bind to selected DNA sequence of the SARS-CoV-2 viral genome. Along with the primers, the process uses probes, which are linked to distinguishable fluorescent reporter and quencher dyes. So the patient sample, the primer, and the probe are together left in the PCR machine for the binding process. And using these probes linked to this distinguishable dyes, which we are able to get the parallel detection of the not only of the target genes, as well as detection of the internal control in the corresponding detector channel of the PCR instrument. So it requires specialized laboratory setup with specific biosafety and biosecurity precautions. Average time taken is 4 to 5 hours, and advantage is accuracy of detection as well as ability to run about 90 samples in a single run. So various PCR assays are used. Different assays amplify and detect different regions of the virus genome. Some target 2 or more genes, including the nucleocapsid or the N gene, envelope gene, which is the first line screening assay for most of the tests, and the spike S gene, which can be the confirmatory. And also the RDRP or the RNA dependent RNA polymerase gene. In India, usually the RDP plus the E gene is used. RDRP plus the helical gene has the best lower limit of detection and the specificity. Ideal design would be to have one conserved region and one specific region to mitigate against the effects of the antigenic drift. At our institute, we are using 2 kits. One kit uses the E gene, RDRP gene, and the N gene, and the other kit uses the E gene and the S gene, and S gene is the confirmatory in that kit. What is the CT value? Number of cycles in an RT-PCR assay which is needed to amplify the viral RNA to reach a detectable level. So the various kits have various cyclic threshold cutoffs. One of a kit which are using here, the CT value is of less than 40 is positive, and if it more than 40 it is negative. If you get a CT value of less than 40 over only one gene, then the test is indeterminate and would require a re. What is TrueNAT? It is a chip-based test which works by detecting the genome and the RDRP gene, S gene and the RDRP gene. Sample preparation is automated and results available in half an hour. The sample swab is similar collection, is dipped in the solution that inactivates virus, making it safe. Few drops are pasted on the cartridge and it is inserted into the machine. And a pre-programmed reaction is initiated which extracts the viral nucleic acid or genetic material from the sample, and this is followed by the RT-PCR. TrueNAT is indigenously developed portable version of the CBNAT or cartridge-based nucleic acid amplification test, which is also known as Gene Expert, which has been earlier used for diagnosis of TB. What are the advantages? A quick turnaround time of only 30 to 60 minutes. Safety because of closed nature and also because of inactivated virus. Can be used at grassroots levels to increase and does increases access to testing, and is widely used at can be widely used at the district and PSC levels also, because they have already been using for the TB. What is the disadvantage? Only 1 to 4 samples can be tested in one run. This is limiting the maximum number of tests that can be run in 24 hours. What are the other technologies? Real-time reverse transcription loop-mediated isothermal amplification PCR method. It has the lowest level of detection. Even one copy can be detected. Test time is 20 minutes versus 4 to 6 hours for RT-PCR. Other is a crisp par-based assay and the next generation sequencing. How do we interpret the NAT? So a positive test confirms the diagnosis of COVID-19, and usually you would not require another test for the diagnosis. Detectable COVID virus is in the upper respiratory tract persists for weeks after the onset of symptoms, and it is not unusual. It is usually unusual to find a isolation of infectious virus from a patient who has had moderate disease after 10 days. Recurrent positive NATs following this, even negative test has been documented in some patients. So what the detectable viral RNA, however, does not always indicate the presence of infectious virus, and infectious virus cannot be detected below certain viral threshold. So how do you, what do you do if you get persistent or recurrent positive NAT? The interpretation of positive test in a recovered COVID positive person undergoing NAT for new symptoms is uncertain. So if you have already COVID positive and you get new symptoms and you get NAT is positive, we don't know whether it's a fresh infection or it's a reinfection. The reinfection of the same. There have been studies that suggest that repeat positive NATs soon after convalescence usually would not represent reinfection. However, CDC suggests that a possibility of reinfection can be considered if a patient has NAT positive more than 6 to 8 weeks after the initial infection. Negative NAT may sometimes be enough to rule out, but usually considering that false negative is 5 to 40% with the NAT, we have to repeat a test if the initial test is negative, especially if the patient has symptoms which cannot be explained by other illnesses, and also necessary for inducing infection control methods. The optimal time of repeat test should be 24 to 48 hours post the first test. Also, repeat test is essential because impact of false negative is more. Imagine a healthcare worker who was tested negative and goes back to work. He can give it to so many patients and his colleagues. Chances of false negative tests increase, especially when the pre-test probability is high. That means if the patient is symptomatic, you know that it's going to be COVID, and then that makes the chance of false negative to be more. So if the patient has signs of LRTI, and if your first RT-PCR from the upper respiratory tract is negative, what the IDC recommends is you collect the sample from the lower respiratory sample, especially in hospitalized patient if possible, which samples expectorated sputum, tracheal secretions, and the bowel. However, induction of sputum with various methods is not recommended because they can generate a lot of aerosols. For hospitalized patients negative, the characteristics fact we can use, whilst we are waiting for the second test, we can use other lab findings or markers of COVID or prognostic markers of COVID along with imaging findings like CT scan to support the diagnosis of COVID. And meanwhile, the infection control practices are followed till we get the result. What happens if a patient comes after 2 weeks of illness with negative NAT? So here we can use a serological test along with the RT-PCR. If a negative NAT but positive IgM or IgG, it would confirm COVID. But if a negative NAT plus negative antibody would decrease the likelihood of COVID. What do you mean by indeterminate NAT? Depends on the specific NAT use, indicates only that only one of the 2 or more genes that the targets was identified and maybe presumed to be positive, but however, it has to be confirmed by a repeat test. Accuracy of NAT, highly specific test. It has a high analytical along with clinical sensitivity, able to accurately detect low levels of viral RNA in the test sample known to contain the viral RNA. False positive is rare, though it is not unknown. It can happen due to mixture of the specimens. What is one of the mechanisms told that it can, if there is a cross contamination between the samples while processing in the lab, and false negative is 5 to 40%. Sensitivity depends on the type and quality of specimen obtained, duration of illness at the time of testing, and the specific assay. Specimen, the lower respiratory tract sample is better than the upper respiratory tract sample. Likewise, that will bowel will be better than sputum than the oropharyngeal swab. Nasopharyngeal swab to some extent is better than the oropharyngeal swab. That's why, and it has to be collected in a specific method. So it has to go to the in the nasal cavity in the up to the medial turbinate and kept there for 10 seconds, swirled, and it should at least induce a tear. That's what has been told. Illness wise, as everybody knows that the viral load is more just 1 day or 2 days before the onset of the symptoms, and it progressively decreases. So what the analysis of studies have shown that the estimated rates of false negative will be 100% on day of exposure, 38% by day 5, 20% by day 8, and 66% at day 21. Data on asymptomatic patients is limited. So by assay, due to difference in the limit of detection amongst various kits or various assays, retesting sample on different platforms may yield conflicting results. Also, point of care NAT assays may not be as sensitive as lab tests. So that's why you might see that people do a test in one lab and then go to the other lab. You might have conflicting results because of the same reason. CT value can indicate the RNA level in the specimen with low So that means lower CT value would indicate a higher viral level. However, CT value usually are not provided and have not been recommended to be provided by the ASMR, and the clinical application is uncertain. Besides, they are not standardized across the RT-PCR platforms, so the results cannot be compared across different tests. No clinical study has validated the use of CT to guide the management, though a lot of it was recommended. And this is a slide which is by the Society of Clinical Microbiologists. They have warned us against using the CT values for guiding the infection control measures, especially if you want to say the patient is positive, CT value is high. So that means a patient may be negative. So what my microbiologists are warning that we should not use CT values to guide the infection control measures and the treatment. What are the antigen tests we have? Rapid point of care antigen test is based on the policy of the ICMR to test, track and treat, and they are being considered as a point of care test for early detection of SARS-CoV. Relatively moderate sensitivity, but very high specificity. So a positive test of antigen test would be considered as a true positive, and all symptomatic positive individuals testing positive test will not require an RT-PCR. However, if they are negative, they would require a real-time RT-PCR. So the standard Q COVID-19 antigen test has been now approved by the ICMR as a point of care diagnostic assay in the containment zones as well as in hospitals, however, in combination with the gold standard RT-PCR. So where it can be used, so in containment zones or hotspots under strict supervision and maintaining the temperature of the kit between 2 to 30 degrees, all symptomatic influenza-like illnesses Asymptomatic direct and high risk contacts with comorbidities from day 5 to day 10 of the contact. In the healthcare settings, again, symptomatic ILI and asymptomatic patients such as chemotherapy, immunosuppressed patients, malignant disease patients, transplant patients, and elderly patients with comorbidities, and also asymptomatic patients who are coming into the hospital for aerosol generating procedures. So advantage of the rapid antigen test is interpretation within 15 to 30 minutes with naked eye. It is, but however, with symptomatic tests, RT-PCR is must. Symptomatic who test positive, no RT-PCR. Only nasopharyngeal swabs are advised for the antigen test, and it has to be conducted on site under medical supervision within 1 hour of sample collection to extraction program. So what to do? Suppose if your patient is coming within a week of the symptoms, we can do a rapid antigen test as a triaging. And if the patient is symptomatic and positive, he can be reported as true positive and treatment and infection control method initiated. If the test is negative and if the patient is symptomatic, you have to repeat an RT-PCR or you have to do an RT-PCR on that patient. If the patient is asymptomatic or a high-risk contact who is asymptomatic, you may declare as negative, but you will have to follow the quarantine process as per the protocols. The antibody test, all immunocompetent individuals will have an immune response following SARS-CoV-2 infection, and they will elicit a development of IgM and IgG antibodies, which are the most useful for assessing the antibody response because little is known about the IgG response. What are the targets are the spike glycoprotein S and the nucleocapsid phosphoprotein N protein. Immunodominant protein that interacts with the RNA. So what are the tests which can be used? Binding antibody, which uses purified proteins of the SARS-CoV-2, not the live virus, and that's why it is safer. A point of care test, which binding antibody detection can be of two types. Point of care test, which have lateral flow devices that detect the antibodies, but this is more of a qualitative. And the lab test, which are ELISA, which can be qualitative as well as quantitative, and the CLIA or the chemiluminescent immunoassay, which can be quantitative and uses whole blood and serum. So point of care advantages, you can do it by finger prick test, and there are even the IgM test kit available in India. So we are in our hospital using the CLIA test. There are also the neutralizing antibody tests, which are not yet authorized. They determine the functional ability of the antibodies to prevent infection of virus in vitro. They will require a higher biosafety because of the use of live virus also. There are two ones, virus neutralization tests, such as the plaque reduction neutralization test and the micro neutralization, and the pseudo virus neutralization test, PVNT. This is a graph of the antibodies, and you see that IgM is generated first, probably in the beginning of first week, and then towards the second week, towards the end of second week, you see the IgG antibody coming up. What is this systematic review showing that IgM was detected in 23% patient by first week, 58% by second week, and 75% by 3 weeks. The corresponding detection of the IgG was 30, 66, and 88%. But the IgG positivity can go to close to 100% by 16 to 20 days. However, the duration in which the antibodies last is uncertain. One study has shown that IgG levels were noted to decline by 75% from the acute to the convalescent phase. And at 8 weeks following infection, 40% of asymptomatic patient and 13% of symptomatic patient did not have detectable IgG. So they identify patients who had COVID-19 in recent past. For a patient coming from 9 to 14 days after the illness, serological test can be offered in addition to RT-PCR, even if it is negative. Serological test may support the diagnosis when patient presents late complications of COVID, such as the multi-system inflammatory syndrome in children. They are prone to high positive, and especially in low prevalence, even if the test will have even if the specific test will have a low positive predictive value. Serological test should not be alone used for diagnosis for the presence or absence of COVID-2 or reinfection.
You'll have to sum up your talk, please.
So because antibodies may not develop, they may not be in detected levels, and they may reflect in early disease. So IgG antibodies are mainly used for sero survey and survey in the vulnerable populations like the frontline workers, and it is strictly advised to use only for ELISA or CLIA methods for sero survey. So what do we recommend? So if you're positive for antibodies, it doesn't mean that you're immune.
Kindly sum up. Put your conclusion slide, please.
Yeah. Yes, sir. See, the initial test always is the RT-PCR or the antigen test for symptomatic individuals. If the symptomatic individuals RT-PCR antigen test positive can be labeled as positive, but if the antigen test is negative, you have to go for an RT-PCR. So most of the hospital settings like ours, we are using the RT-PCR only, because even if the test is negative, you have to again make the patient go through an RT-PCR. Antibody test can be used, as I told earlier, that for patients who are coming in into the 9th or into the 2nd week of their illness, if their RT-PCR is negative, but the antibody IgM or IgG comes positive, you know that they've had a recent infection. And it also for the antibody tests are used basically only for the surveillance purposes, less than and not recommended usually for the diagnostic purposes. Thank you.
Before we have this question answers, there will be a small Just Look Hospital video which will be run for a minute or so, and then I'll ask the question. There are lots of questions for all the speakers, so we will pick up few and ask, and rest of them you can try and answer them on the chat box. Great, thank you. So we're loaded with questions. Hemant, you ready? The first two questions I'll ask you because there are lots of them. I can see Hemant. Hemant, there's a question directed to you. Is in a COVID suspect whose RT-PCR is negative, if he is getting a lot of productive cough and phlegm, can we check the RT-PCR from the sputum sample, and what do the pathologists say?
Absolutely right. If the RT-PCR from the traditional nasal and throat is negative, and if the CT scan is suggestive, you have a high index of suspicion, the sputum yield will give you a better answer than the traditional. This is where the complement from the radiologist, where the X-ray and CT findings complement the clinical suspicion, is extremely important. I would go for the repeat sample rather than the rapid antigen test, because you want to be on this side or that. You don't want to be on the verge. So you want to be careful, and I would definitely ask a sputum sample.
Good. Hemant, another one for you. What are the good imperative general tests for acute high-grade fever?
Good question. Of course, CBC is important. Depending on the pattern and the season, a malarial parasite, a dengue, NS1 and IgM. This will rule out the traditional monsoon illnesses. Then you should look at a single liver function test like SGPT. OT is not important. Look at the financial crunch. If you do SGPT and maybe complement it with bilirubin, you will get hepatic function. A urine routine is very important because a lurking urinary tract infection, often forgotten because patients go to give blood and don't give urine. And the last is in an elderly patient, look at creatinine. Of course, if it is indicated, a plain and simple X-ray chest. This will cover everything. Malaria, the dengue, urine, kidney, and lungs. I would do that. I wouldn't jump in for blood cultures and urine culture straight away, which is the fashion these days, because more than the disease pays a huge bill for the cultures. By the time the yield from the cultures comes, more often negative than positive, either the patient is hospitalized or the patient has recovered, more often than not recovered.
Good. Thanks, Hemant. Sudeshna, the few
Yes.
questions for you. What are the guidelines for managing 4-month pregnant woman who is COVID negative?
Okay.
What are the guidelines for managing 4-month pregnant woman who is COVID negative but has COVID positive husband?
Yeah. So this is a question that has come. I'm seeing in the chat that many. So if the husband is COVID positive, there is absolutely no need to panic. There are, if you can isolate the pregnant women from the husband, then there are very, very few chance that the pregnant woman will also get COVID positive. And through my presentation, you have seen that it's even if she becomes COVID positive, it is not that dangerous. But if the husband is positive, I had dealt about more than 9 patients whose husbands were positive, and all of these 9 patients did not become positive because they have shifted to their mother's place from the husband's home. So if you can isolate the woman, then most of the times the pregnancy is not affected. And even if it is affected, as I said before, that there is absolutely not a major reason to panic, especially at the 4th month. The complication rate is extremely low in the 1st and the 2nd trimester of pregnancy. Does that answer
Right.
the question? I hope. Yes.
It does. Now there's so many questions about the pregnancy. Trust me.
I know.
You have to ask.
I
Okay,
have chatted this thing. One, I wanted to answer myself is there have been 3 questions on this. Is it a good time to plan a pregnancy?
That's
Can
right.
I take that
That's right.
question?
Yeah, please.
Okay.
Because I was going to ask you the same question.
Okay. So it's that's a very interesting question. Now, honestly, this is a lockdown time is utilized by many couples to plan the pregnancy well, and there is no reason why they cannot do it, especially if they have accepted the fact that a part of their consultation would be virtual, a part of their care will be virtual, and the access to the hospital might not be very easy. So I would say what the literature says is that if you had some kind of a high risk factor in the previous pregnancy, for example, if she had a high blood pressure or she's diabetic or something which needs an extra care during pregnancy, this is not definitely an ideal time to get pregnant, because the care model is somewhat suboptimal and the access to the healthcare might be a little compromised. So not for high risk pregnancy, but low risk pregnancies and primary gravidas can just go ahead and enjoy.
And
Yeah?
Indraneel, there are a few questions for you. Which blood test should be done on the first day of a corona suspect?
Yeah, so we should do a CBC, a creatinine, previous SGLT, SGPT, a D-dimer, LDH, and CRP.
Okay, great. All the speakers.
Ferritin. What about ferritin?
Ferritin, I would do it only if the patient
Not on day 1.
Not on day 1. Of course, not on day 1.
Not on day 1.
Neither the IL-6 also should not be done on day 1. It should
Fine.
be also and later.
Yeah, it requires time to come up.
Yeah.
If I may interject, do tests that are going to help you to treat. Just because the bandwagon says ferritin and IL-6, remember 2 people are paying for it. Either the hospital is paying out of that small little measly budget, or the insurance is paying. So please be full and judiciously use your clinical judgment. Thank you.
Oh, good. Thanks, Hemant, for that. So thank you all the speakers. Fantastic lectures, very, very self-explanatory. But you are hundreds of questions there. So please go to the chat box and the question and answers. And if you have time, try and answer those questions. Now, and the time does not permit us to continue with more questions. So we'll have to go to the next talk now. And we have a very interesting session coming up, that acute ischemic strokes in COVID times, cause or coincidence, and management thereof. Because we're seeing so many strokes. Question is whether strokes are associated in the cases of the COVID, or COVID is the cause. And we have our Director of Neurology, Dr. Joy Desai, who will be talking in stroke in COVID times. Before that, Sarosh, if you want to have any comment, and then you can hand over to Joy.
Yeah. In the last part 1, Dr. Ashwin Mehta mentioned that somehow the other acute MIs have become uncommon. Maybe the patients are not going to the hospital for fear of COVID. However, I think the incidence of stroke seems to have gone up during this COVID times, and many patients turn positive for COVID in the immediate recovery period of the stroke. Therefore, this title of this talk is acute ischemic strokes. Is COVID the cause, or is it just mere coincidence? And if COVID is the cause, then what is the management? Or if COVID is not the cause, then what is the management? Over to Dr. Joy Desai.
Thank you very much. It's a great pleasure to be here. And so the pertinent questions we clinicians ought to be asking is that what is the relationship between COVID infection and stroke? Does COVID infection increase the stroke risk in a vulnerable population that's suffering from COVID? Does it affect the outcome of stroke? And this is an area which hasn't been fully answered yet, but there are some emerging signs that we may learn more about it. What are the mechanisms, as Dr. Katrak put it, that lead to a suspected increase in a stroke risk amongst patients who have COVID? And does the management of stroke change with the advent of the COVID pandemic? Surely it does. We've all been seeing that. And I shall share with you some of the vignettes of information that we have, both from our hospital, from other experiences in Mumbai city and globally. And finally, what does our experience in the last 4 months imply in terms of management and our understanding of stroke risk? So the first vignette of this relationship between COVID and stroke came about with this letter to the editor that was published in the Journal of Neurology, Neurosurgery and Psychiatry from the National Hospital for Neurology and Neurosurgery in Queen Square. And this letter was a description of 6 patients in the early part of the pandemic. And these 6 patients ranged in age from 53 to 83. And essentially, what they delineated was that between 10 days to 8 days to 15 days and 24 days from COVID onset, some of these patients experienced a stroke, though they had other risk factors. What was striking in the workup is that at the time that these patients had a stroke, all of them at that time had an increased fibrinogen level. All of them had a very high D-dimer level in their serology. And all of them, what came through very clearly in these patients is that these were all large vessel strokes. In 2 patients, there were multiple territories that were involved. And in 2 patients, there was a concurrent venous and arterial thromboembolism. And as I showed you in the table, all of these patients had elevated D-dimer levels, and all of these patients had elevated fibrinogen levels. My slides are not moving again. So then the key question was, does COVID-19, is it an independent risk factor for acute ischemic stroke? So we have a case control study from Mount Sinai, wherein 41 cases of stroke and 82 control subjects were assessed in a case control paradigm at Mount Sinai. And these were patients from the hospital itself and 4 of the training other hospitals that sent patients with stroke to Mount Sinai. And what they found there is that if one looks at the presence of COVID, in patients with acute stroke, the prevalence of COVID was 46.3%, whereas in the control population, it was only 18%. And their conclusion was that clearly it appears that there is a higher predilection for COVID to produce stroke in patients who have the systemic infection. Around the same time, this review article was published from All India Institute of Medical Sciences by Rohit Bhatia and MV Padma. And they hypothesized various mechanisms, as shown here in this graphic representation, that just like we know that the AC2 receptor is an important receptacle for acquisition of the virus in the respiratory tree, we know that the AC2 receptors have high density in vasculature, and they propose that perhaps the occurrence of vascular events in COVID could be related to this pathophysiological vulnerability. And finally, a very startling and alarming publication got published about last month. This was a paper in which delineated 3 patients in an American hospital, wherein the 3 patients presented with acute gangrenous intestinal obstruction. And what was demonstrated when their surgical resection was done was that the vasculature of their intestines was teeming with viral inclusion bodies and the presence of COVID virus within the adventitia of the vessels. And the authors, as you can see here, have hypothesized that COVID is an endothelial cell infection. And at the NIH, it became very clear that it has a propensity to involve the endothelium. Can we go to the next slide? So what's the Mumbai experience? If one looks at Jaslok in this period of time, despite the initial period when we were shut down, we had 28 stroke admissions. 8 of these were COVID associated. There were 2 hemorrhages, 6 thrombotic events. 1 patient had coexistent venous and arterial cerebral infarcts. 3 of these patients were thrombolized. 1 had a hemicraniectomy, and we lost 1 patient with COVID and stroke in this period. I spoke to my colleagues at Fortis Hospital in Mulund. They had 35 acute strokes with COVID. 78.6% were thrombotic. 10.7 were venous and hemorrhages. There were 2 patients who had coexistent venous and arterial infarcts in the brain, and 14% of their stroke patients were thrombolized. And the HRCT chest was abnormal in a good 70%. At the HN Reliance Hospital, there's been a variable experience during this period of time due to various logistic reasons. Some of these patients with stroke, once they were diagnosed to have COVID, were transferred to the Seven Hills Hospital. In the month of July, there were 25 stroke cases, 8 of which were COVID positive, 6 were ischemic, 1 was hemorrhagic. 3 of these patients underwent a mechanical thrombectomy, 2 received thrombolysis, and 1 underwent a decompressive craniectomy. And needless to say, their experience was similar. Most of these patients had a very high D-dimer levels above 5,000, and 1 patient who had very severe illness had a D-dimer level of 39,000. This is one of our patients who is currently in the hospital here at Jaslok. This is an 86-year-old person who developed stroke 5th day into the COVID infection. And you can see on the diffusion weighted images that this is a large vessel occlusion with multiple areas in the right side, in the middle cerebral, anterior and posterior divisions of middle cerebral artery, both cortical and penetrating distribution of this vessel are affected by the infarct. And if one asks this question, that has the incidence of stroke changed? This is data from the Reliance Hospital last year and this year. Last year's data is shown in the blue bar charts. This year's data is shown in the orange bar charts. And on the extreme right, you can see June and July. And though there is a subtle increase in the numbers, this does not seem to be very significant. And there could be other logistical reasons why this is so, because in the community, this hospital is considered as a non-COVID hospital because the patients get transferred to Seven Hills, and perhaps that could be the increase in numbers. So we're not really sure that the stroke numbers have increased in these COVID times. And an assessment was done with an international panel as to ask the question that how do we deal with strokes in COVID times? And this international panel came up with an algorithm. The algorithm was fairly clear that every patient who presents with a stroke should be screened for COVID as a screening paradigm, just as is being done in Jaslok. Here, all our patients are screened with a throat swab for RT-PCR and a chest CT scan for presence of occult or asymptomatic or minimally symptomatic disease. The management of stroke does not really change. Those who need thrombolysis would need thrombolysis, but there's a small caveat. If the D-dimer levels are very high and if there is an evidence of coagulopathy, this could increase the risk of hemorrhagic transformation. And mechanical thrombectomy is also not contraindicated, but it needs a full PPE during this period of time for mechanical thrombectomy to actually occur. So what are our take-home messages? There is very clear emerging evidence that stroke could be a leading presentation of CNS dysfunction in patients with COVID. There is some evidence that COVID could lead to an increased risk of stroke, but the jury is not out yet because we have only one case-controlled study in international literature, and perhaps as time goes by, we'll learn more about this. Many vignettes of clinical experience suggest that a systemic inflammatory response of a very high degree with a very high D-dimer level is a large contributory factor to the risk of developing thrombosis in the central nervous system. It remains to be seen whether COVID survivors are at a higher risk for future strokes. We know that there is a study from Germany which has shown on MRI that even in mildly symptomatic or minimally symptomatic COVID patients, when followed up over a period of time, there is evidence of ongoing myocardial inflammation. We don't have data of this kind for the CNS vasculature at this moment. And it appears that the question, should survivors of COVID and people who have had COVID infection, even if they have not had any vascular events, should they be put on aspirin? And the jury is not out here at this moment, and we don't know. And I hope that perhaps as time goes by, we'll learn more about this. This is my last slide. Thank you for your attention, and apologies for the glitch in the technical aspects of getting the slides visible to the audience at large. Thank you very much.
Thank you, Joy. Thank you very much. I think you have outlined all the problems associated with strokes in COVID and postulated the possible causes when one can say that COVID is responsible for the stroke. One of the questions that I saw is, when you say high levels of D-dimer, how do you define high levels?
If D-dimer,
I think that is a question that we'll answer in the question answer session.
fair enough.
Yes, Sarosh, let's keep the Q. Yeah, because we are running.
Yeah, fine. I think, thank you very much, Joy. Now we will go on to the next speaker, who is Dr. Ameet Pispati, Director of Orthopedics at Jaslok Hospital. And his talk is on, should orthopedic surgeries wait until COVID crisis is over? Over to Dr. Ameet Pispati.
Respected chairpersons, ladies and gentlemen, as we all begin to adjust to the new normal and slowly begin to accept that this virus is pretty much going to be a part of our lives for the next few years at least, it's time to assess whether we can slowly and surely begin to resume our elective orthopedic surgery program. I fully appreciate that our colleagues in other specialties have already begun to perform their routine surgeries, but then we orthopedic surgeons have always been a different lot, haven't we? We've traditionally been perceived to be more bold and daring, and yet on this occasion, we've taken a back seat and we've been extremely cautious. I'm sure you'd appreciate Sir William Osler having said a long time ago that medicine is a science of uncertainty and an art of probability, and it's entirely true when it comes to COVID-19. Until now, the mantra clearly was stay at home, stay safe. But if we are going to resume our elective orthopedic surgeries, we've got to be absolutely sure that the benefits of such surgery far outweigh the risks. We want to make sure that under no circumstances are the risks going to be well more than the benefits. As early as the end of March 2020, our Indian Orthopedic Association came out with guidelines. But at that time, we were very new and early into the pandemic in India. We surgeons were running about helter-skelter, not knowing what to do. So then the guidelines were different. We had to maintain emergency surgery capabilities. We had to do strictly emergency work. We had to protect and preserve ourselves. And we had to employ non-surgical solutions, even in emergency scenarios, as much as possible. And we were encouraged to avoid routine follow-ups. If we now had to resume elective surgeries, I'm sure you want to ask me, Doc, what's your plan? And in order to have a plan, we need to understand what do we mean by elective orthopedic surgery. By that we refer to non-life or non-limb threatening surgery, anything that traditionally involves pain relief surgery, arthritis surgery, surgery for limb deformities, chronic infection, ligamentous instability, the usual typical low back pain with radiation, lumbar disc prolapse without neurologic deficit, a routine pediatric orthopedic surgery, and the likes thereof. The concept here would be, in performing elective surgery, that we implement practices and protocols to minimize the risk or avoid the risk of pathogen transfer. And that's going to be unique to each hospital. What applies to Just Slope may not apply to Breach Candy or to any other neighboring hospital or even to a hospital far away from us. It is critical to have an excellent screening system in place for the coronavirus to be allowed to perform elective surgery. And I think we've managed to achieve that here at Just Slope. We need a good history-taking protocol, an examination system, the ability to have reliable RT-PCR tests, a preoperative chest CT prior to performing our elective surgeries. But what is of paramount importance in orthopedic surgery is that patients who are currently infected with COVID-19, that means those who test positive for the coronavirus on a COVID-19 test, should not undergo elective orthopedic surgery. And when should we then resume our elective surgeries? That needs to be done when the cases in the region are consistently declining. And I think we are seeing that happen here in the Mumbai region. When the hospital has the facility to admit non-COVID patients in a separate area of the hospital, like we have at Just Slope Hospital, like a green zone area. When the hospital has an adequate supply of PPE, testing kits, appropriate safe OT protocols, adequate residents and assistants, and when we have an adequate stockpile for a second potential wave, as we have over here. Now, why did we say no to surgery in those patients who test positive for the coronavirus? That's simply because these patients have the ability to infect our healthcare workers, who will then move on to infect other healthcare workers, who will infect non-COVID patients, who will then pass on the infections back to the community. More importantly, studies have already shown that positive COVID-19 patients have a high perioperative complication rate as well as a high mortality rate. Take, for example, this study published in the Bone and Joint Surgery Journal, which is our best orthopedic surgery journal, and published straight from Wuhan. Mind you, this was published early on in the pandemic, so not all the recommendations may hold true today. But the conclusion from this was that surgical treatment should be carried out cautiously, or even non-operative care should be chosen for patients who have fractures and are COVID-19 positive. Mind you, traditionally, people who come to us with hip fractures always have surgery out of necessity, but this study even suggested that patients with the typical intertrochanteric hip fractures should also be considered for non-operative intervention. Times have now changed 5 months into the pandemic in India. So if somebody today came to us with an intertrochanteric fracture and were COVID-19 positive, we'd take other parameters into account. We would do a risk stratification, assess the other comorbidities, and then we'd make a decision on when to operate upon him. We'd also consider whether he could wait out a 10 or 11-day time period, become non-infectious, and could then undergo a surgery at that point in time. There's another study published in June from JAMA. It was a matched cohort study which looked at surgical mortality and complications and found them to be higher in COVID-19 patients compared with patients without COVID-19, and also recommended that when possible, surgery should be postponed in those patients who were COVID-19 positive. Another important study in the Lancet towards the end of May or early June, which was an international multi-center, multi-specialty study. So it was not only for orthopedics, but considered GI surgery and many other specialties, looked at emergency and elective patients, but specifically for orthopedics, the 30-day mortality was 28.8%. The morbidity and mortality rates were higher in older patients, in men, and in emergency compared to elective patients. And this study also showed a very high pulmonary complication rate. And this was true for the COVID-19 patients. Now, which are the group of patients that I would consider or recommended for elective surgery if we had to start performing this today, as we now plan to start doing those? One should start with the youngest patients without comorbidities and patients who need soft tissue surgeries. These are the first lot of patients who should undergo surgery. The next lot of patients would be the middle-aged or the slightly older patients without comorbidities. And finally, the older patients less than 70 to 75 years of age without comorbidities. If one had to further extend the indications, they should be patients up to 70 to 75 years of age with a single comorbidity. If one wants to consider joint replacement surgery at all, then one should make sure they do not have any comorbid conditions such as diabetes, obesity, COPD, sleep apnea, active cancer, or recent radiation therapy. For joint replacement surgery, one should make sure there's an ICU bed availability, because we know that 5 to 15% of such patients land up going into ICU for strange unknown reasons. Therefore, soft tissue surgeries are absolutely safe to perform because these are younger to middle-aged patients, or even the older patients without comorbidities. Arthroscopic surgeries are quick in, quick out surgeries and are safe. And in joint replacements, we need to judge the situation. Patients need to be counseled adequately for surgeries in terms of pre-op fitness, a COVID test in 48 to 72 hours before surgery. They need to be explained that there's a possibility of turning COVID positive in the hospital or after discharge. They also have to be told that if they were COVID positive in the past, they could turn COVID positive again. They and their relatives have to be told about their role in the hospital, what should be their behavior in the hospital, and the fact they all need to wear masks in the hospital. The OR needs to be designed appropriately, which we have a system for that in our hospital. We need minimum 20 air exchanges per hour. We need HEPA filters in the OT to remove aerosol, and even positive pressure rooms in COVID negative patients are absolutely fine with us. Our surgeries carry a very high aerosol risk because of use of hammers, drill, saws, burrs, cautery, fluid, and irrigation systems that we use. The surgical helmets that we traditionally use are not to be used these days because they can harbor the virus in them. And there's no standard protocol now in place to disinfect those. Therefore, N95 mask with a face shield is absolutely fine. And regional anesthetic is preferred. After surgery, every bit of item needs to be cleaned thoroughly in the OT, and we use absorbable sutures with occlusive dressings so that we don't need to call patients to the hospital again and again. The thromboembolic prophylaxis needs to be used after major orthopedic surgery, and it doesn't need to be altered. People have been asking about non-steroidal anti-inflammatory drugs. Early on in the pandemic towards March, people felt that ibuprofen shouldn't need to be used, but recent data shows that non-steroidal anti-inflammatory drugs are absolutely safe to be used after orthopedic surgery, and routine protocols can continue. We encourage minimal hospital stay, encourage post-op telemed rounds and telemed consults. Virtual consultation should be the norm, with least intervention in terms of meeting patients. What's important is this article in The Guardian from just a few days ago, where our colleague consultants from the NHS warned their own government because they found that patients who didn't have COVID-19 were huge sufferers, particularly from the orthopedics point of view, because their care suffered because all care was diverted to COVID-19 patients. And we need to learn lessons from that. So where do we stand at Just Look? I think we have a good screening process for patients. We have adequate PPE and testing facility, good OT facilities, excellent pre-op and post-op medical services, and most importantly, very good communication between us consultants. So then, to cut a long story short, to get to the point, I think we are good to go at our hospital in terms of elective surgery, but we need to be cautious in our patient selection, learn by risk stratification, and it is going to be a tightrope walk, but I think we can manage it quite well once we resume our elective surgeries. Thank you so much for your attention.
Thank you, Amit, for a very clear, lucid, and crisp talk on surgery in this time, orthopedic surgery in these times. I think there are going to be many questions, so please remain with us. Now, the next speaker is going to be Dr. Nilesh Doctor, who is the Clinical Director of Gastrointestinal Surgery. And he is going to talk, is COVID an obstacle for regular GI surgeries? Now, it is known that COVID can produce GI emergencies. And therefore, it would be very interesting to listen to his talk. Over to Dr. Nilesh Doctor. Thank you.
Thank you, Dr. Katrak, and thank you for the organizers to invite me for this talk. Good morning to all the listeners. So when the pandemic first started and the lockdown was announced in the end of March, there were a lot of concerns. So today we want to ask that question. Currently, what is the problem, the GI problem that we are facing? And why was there a concern? So essentially the concerns were patient concerns and concerns for healthcare workers. So right in the beginning of the pandemic, we got a lot of data suggesting that the case fatality rate and the characteristics of patients dying who were COVID positive and underwent surgeries was quite high. There were 34 patients in ICU, mortality was around 20%. This was very alarming to most surgeons all over the world, and there was a kind of moratorium on surgeries. This similar paper in the Lancet, which Amit also alluded to, there was a high mortality and pulmonary complications in patients undergoing surgery. So these were patients who presented to the hospital, were not known to have COVID-19 infection initially, were not tested properly. And you can see this paper was published in May 29 for surgeries done between January to May. So the problem of pulmonary complications was very high in the earlier period, and there was a kind of complete stoppage of surgeries done at that time. So the initial recommendations coming out in the months of April and May were to not operate on COVID positive patients as far as possible, stop all elective surgeries, operate only on life-threatening emergencies with appropriate precautions and counseling. And lastly, most importantly, and the thing that has changed a lot in the last 3 months, is do not do any laparoscopic surgeries, as they may increase COVID-19 transmission. So after the initial period in March and April and middle of May, where we did about 10 or 15 surgeries on emergency gallbladders, acute appendicitis with perforation, those patients were all operated by an open method, because there was a concern that laparoscopic surgery could increase the infection and could spread infection to healthcare workers in the OT environment, and could lead to higher complication rates in these patients post-operatively. But by the end of May, beginning of June, there was a thought process and a planning to try and re-establish this. Of course, this was helped a lot by interaction with the management, motivating the staff in the OR environment, infrastructural changes, patient counseling, as patients were suffering more and more over the last 3 months because of postponement of surgery, and a lot of guidelines from surgical societies based on published data. So if you can see, this is the IAGIS, which is the Laparoscopic Surgery Association, made a kind of flow chart and a guideline along with consultation of all the laparoscopic surgery surgeons from all over the country. And they essentially said that if the surgery could be put off for 2 or 3 months, that would, if it did not impact survival, especially in cancer surgeries, you should put them off so that you do not risk getting the patient or healthcare workers infected. So this was in the initial period where it was thought that delaying surgery was beneficial. The second part was the consent. So there's a lot of discussion on how to consent patients, and most hospitals have kind of a twofold consent form, where one consent is trying to tell the patient that the hospital environment may be dangerous for them and their relatives, and to take a consent that they are aware of this. And the second is, of course, the increased problems that they could have immediately post-op. So even now for surgeries in GI surgeries, only if there's an acute problem like acute appendicitis, acute cholecystitis, those are the situations where you would consider treatment for these patients. If a patient has got asymptomatic gallstones, which doesn't require treatment, they obviously wait. But patients who have got very mild symptoms, they can wait out this period and be treated symptomatically. So before any surgery is done now, we do a COVID testing, an RT-PCR and an HRCT. These two tests help us in strategizing patients who are safe to undergo surgery. If both these tests are negative, that means you have a low CORAD score as well as a RT-PCR which is negative, a large percentage of these patients can undergo surgery very safely. One of the other problems that I said has seen the biggest change in laparoscopic in GI surgery is the change from not doing laparoscopic surgery to now considering laparoscopic surgery with appropriate care. So what is this appropriate care that we have kind of now established? So the Association of Surgeons of India and the Association of Minimal Access Surgeons of India have made a kind of rule of 20 in this 2020 pandemic, which Amit alluded to earlier. So if you have a 20 number of air changes per hour, 20 minutes before intubation and extubation, ACs are kept off and positive pressure is switched off, because to change an OT from a positive pressure to a negative pressure room is very difficult. So the easiest thing to do is to switch off positive pressure during the 20 minutes at the time the patient is wheeled in, but 20 minutes after intubation to enter OT for surgeons and nurses, 20 degrees Celsius temperature, and a 20-minute minimum waiting time after the patient is shifted out to start cleaning the theater. A PPE which is worn, the kind of PPE which can be worn in the OT, there are different types described now. I won't go into too many details, but essentially gloves, shoe covers, face shield, and a a triple ply or N95 surgical mask is worn. For long surgeries, if you are going to go for surgeries which take 4 to 5 to 6 hours, the problem could be that you, with a mask, you can get very suffocated. So you can have a powered air purifying respirator, PAPR system, which helps in keeping the surgeon also comfortable. The N95 mask and the elastomeric respirator are the two most important masking equipments. And if you have a good masking facility, that's all that is really required for prevention of transmission to healthcare workers. A surgical approach, as I said, initial guidelines from the Royal College of Surgeons said that consider laparoscopy only in selected individuals and largely try to avoid laparoscopic surgery. But now the guidelines are very clear. The SSO guidelines tell us that the proven benefits of minimally invasive surgery, if you read the last line, of reduced length of stay and complications, should be strongly considered in all patients. The important thing is to manage the filtration of aerosolized particles, which may be difficult during open surgery. So it's important that actually now minimally invasive surgery or laparoscopic surgery is seen to be by most associations beneficial to these patients because there's less blood loss, less exposure, and if you are able to manage the plume, that is the smoke coming out of the diathermy properly, and you're able to reduce the hospital stay of that patient, you are actually seeing benefits of doing laparoscopic surgery in GI surgeries in patients who, because you reduce the number of people working around the patient who are close to the patient, and you also reduce the amount of time that the patient needs to stay in the hospital. So slowly from March and April, we have moved into June and July into doing all surgeries laparoscopically with adequate precautions. You can see this paper published from Tata Hospital, which is now also moved over from doing colorectal surgeries open in the months of April and May to doing them laparoscopically now. There's a lot of benefits that are seen. As you can see here, if it's robot assisted or laparoscopic surgery, you can see that the smoke is more confined. It can be filtered better, whereas open surgery, the aerosolization of the smoke is widespread, and that can cause more of a problem to healthcare workers around. Abdominal pressure can be minimized. The number of people who are around the patient, who are close to the patient where the transmission risk may be high, is reduced in a conventional laparoscopy and even more reduced in robotic surgery. So these can be very, very safely done. So the guidelines which have now evolved for the months of July and August tell us very clearly that lap surgery can be done very safely because there's less blood loss, shorter hospital stays, better control of diathermy gases, and less healthcare workers around. So what precautions do we take from all the data that is available to us now? Essentially, we have to try and make sure that the ports that we use for laparoscopic surgery are made relatively leak-proof, so nothing really leaks out of all these ports. The energy sources that we try to use electrocautery settings at a minimum. Use of ultracession or biclam is minimized, and low temperature devices with active cellular components are the ones which are actually much safer. We know that there are a lot of hazards of surgical smoke, and this has been enhanced in the COVID era. So there are a lot of very easy to manage smoke evacuation devices. And what we use now in Jaslok is the simple method by which we connect a suction tubing to a hypochlorite solution, and all the gas which comes out of the laparoscopy is filtered through a hypochlorite solution very, very easily. And this reduces the incidence of the smoke causing contamination in the OT or being a risk to healthcare workers. So in the last 2 months, majority of surgeries we have done have all been laparoscopic, and neither the patient nor any of the healthcare workers have had any problem. We have improved the ERAS protocols to reduce the number of problems that the patient can have after GI surgery. For example, as you all know, patients have Ryle's tubes and catheters, and these could all be risk factors for healthcare workers. So we have actually, there's a lot of data to suggest now that you do not need, you can avoid surgical drains in most patients. You use normothermia or euvolemia intraoperatively so that the hospital stay is reduced. Clear fluids can be used just 2 hours prior to the surgery. Early mobilization is very useful so that you can discharge the patient quickly. and narcotic sparing post-operative analgesia could be useful. So we use a lot of enhanced recovery protocols now so that these patients stay very less time in the hospital. Now we have also started operating for COVID positive patients. Obviously, if the patient is COVID positive, unless the surgery is emergency and life-threatening. So the surgeries have now been very well classified. So emergency life-threatening would mean massive GI bleed, which requires surgery, the patient is hypotensive, or there is bowel gangrene. And if the patient is COVID positive, if you do not operate this patient, they will die in a few hours or in 24 hours. So it's very important that you take adequate precautions, and only those patients who are COVID positive and need a life-threatening intervention are allowed to, should be operated by the current guidelines. If they do not have an emergency or a life-threatening situation, quarantine and monitor, repeat COVID and chest CT after 2 weeks. If the patient is RT-PCR negative and the chest CT is normal, then you can safely do the surgery at that stage. If the patient is persistently COVID positive, you need to reevaluate your clinical indication. For example, you may have a GI cancer which requires, which is bleeding or which is going into obstruction. So you can evaluate what the clinical indication is. Supposing the clinical indication is resolved, it's not a cancer indication, you can wait for a little longer and make sure that the patient's lung function is completely returned to normal prior to undergoing surgery. If, however, if the patient is, say, has got a cancer at the time of presentation and is COVID positive, wait for 2 weeks. If the lung function is returned to normal and the chest CT is returned to normal, and the indication for surgery is strong, for example, if the patient is bleeding or if the patient is having obstruction, then you can go ahead with surgery at this time. There are other simple methods like a 6-minute walking test, which tells us that the lung function is recovered. If there is no urgent indication, wait for 4 to 6 weeks and then operate on COVID positive patients. So in conclusion, I can say that we have evolved from the time of the immediate pandemic, that GI and lab surgery can very safely be performed now in the COVID era with adequate precautions and adoption of safety protocols for both the patients and the healthcare workers. And patients who are COVID positive should be postponed if possible and reevaluated after 2 weeks. Safety will depend on the recovery of lung function and the urgency of operative indication. Thank you very much.
Thank you, Nilesh, for a very lucid and crisp outline of the guidelines for operations in GI surgery. I think now I will request all the 3 speakers to switch on their videos and hand over the mic to Dr. Shrinivas Desai for the questions.
Very explanatory, I think, and very educative. And there are lots of questions pouring in. But before we ask the questions, the hospital wants to again show the video of the hospital. So we will see that and then I'll ask the questions. With a patient with a stroke, with a post-COVID patient, how many days you can continue after that, the antiplatelets and statins. And when the patient's lipid profile was normal prior to the stroke, and he did not have any known comorbidities.
So at the moment, we are not very sure whether COVID by itself is an independent risk factor. There's a suspicion that COVID infection could infer an independent risk factor for thrombotic events. We do know that there is a propensity for the virus to involve the endothelium, and therefore vasculature could be at risk. So patients who had a stroke will need an antiplatelet and a statin. The minimum period is for at least 6 months in the post-stroke period, as per all our regular patients. The unresolved question is really whether post-COVID, a patient who's not had ischemic symptoms, whether there is a merit in antiplatelet prophylaxis. And we don't know the answer to that at the moment.
Okay. The next question is a little interesting, and it might interest you. Is COVID smell problem will take how many days to return back to normal?
Yes, so there are a few publications. There is a very lucid article that was published by a neurology resident from Columbia in New York in the early part of the pandemic. And she narrated her experience, and she's reviewed some of the literature in neurology. The literature seems to suggest that the recovery period is from between 2 months to 3 months. So olfaction, if an individual survives COVID, then the prognosis for olfaction is good, and the recovery is from 2 to 3 months.
Great, thanks. Is Amit there? Amit, there is a question.
Yes, I'm here.
Yeah. When can a COVID-19 positive patient be operated safely, as complications in positive patients have been reported up to 28 days? And what are the post-positive tests to be performed?
If somebody is COVID-19 positive and you're looking at performing an elective surgery, then there's absolutely no rush at all, because it's an elective surgery. So one could wait out a full month or two, take your time, optimize his condition, and then operate on him. I think this issue comes up for somebody who's come to you in a semi-emergency state. So say for somebody who's come to you with, for example, say an ankle fracture and who's turned out to be COVID positive. I think that's where the dilemma is. So in that scenario, one would have to wait out approximately 12 to 14 days, repeat the test, make sure that he's clinically okay. We know that after about 11 or 12 days, they turn out to be non-infective. And that's the time period we could go ahead and do the surgery.
Thanks, Amit. And there is next question, which is practical question. You are already, I think you addressed that in your talk. Would you recommend a surgical treatment for a 95-year-old patient with fracture hip?
Yes. So it's like this. I think if a patient has a hip fracture, firstly, they're going to come to hospital. They're going to have a COVID test on them. Now, if they're COVID negative, I think, of course, they're going to need a surgery because they're COVID negative, and we need to improve their quality of life, prevent complications like bed sore, etc. But if they're going to be COVID positive, then I think there's that classical phrase, you're damned if you do and you're damned if you don't. If you don't operate on them, you're going to land up in trouble. But if you operate on them, at that point, you're going to be in greater trouble. Therefore, wisdom should prevail. The guidelines need to be prevail, and the guidelines we still have in place are to wait it out. And I still need to wait out that 2-week period, wait till they're COVID negative. I have to counsel the family of the also that would have to follow by even waiting it out. But I'll have to tell them that the risks of operating whilst they're COVID positive are far higher than those of a fracture neck or femur, and therefore I'll have to wait it out at that point in time.
Thanks, Amit. Nilesh,
Yes.
your OT talk has impressed somebody and has asked him, are our OTs laminar flow? And,
so
are
that,
and are UVC filters or HEPA filters installed?
Yeah. So that's a very good question because there was initially move towards making negative pressures in all OTs to make them safe, but that's really not required now. As I showed you a slide in which we talked about reducing the pressure to normal for the 20 minutes before, the 2020 rule for 2020 is the one which is now recommended by Association of Surgeons of India and all minimal access societies. So where you do not need negative pressure in the OT, you have of course HEPA filters, but you normalize the pressure for 20 minutes at the time of induction. During the surgery, go back to a normal pressure environment, and then after the surgery again go back to reducing the pressure. So at the time of those 20 minutes, at the time when you extubate the patient, you minimize the risk to the patient as well as to healthcare workers because of aerosolization from the bronchial tree. So you do not need to make a specific negative pressure OT, which was initially recommended in the first 3-4 months back, that you need all OTs to be completely negative pressure to do safe surgery, but that's not required now. Filtration and normal pressure, what we have just now in Just Look is absolutely safe for doing these surgeries.
And one related to the same one, they asked what is the rate of infection to OT personnel in MIS?
So again, that's a very good question. Now that we have all the safeguards in place, that means if you manage your plume well, that means the smoke coming out of the cautery is managed well. And if the use of your diathermy is very judicious, then the risk of the OT personnel is very low. There has been 2 papers, one from Manipal Hospital and one from Tata Hospital, where over a 3-month period, that paper was published in the annals. All cancer surgeries are in Tata, and Manipal Hospital, all minimal access surgeries, which were done in the month of May and June, was published. So there they have had not a single person. There were 3 people in Tata Hospital in open surgeries and not a single patient in minimal access surgeries from Manipal Hospital. Over, I think, 84 or 85 surgeries that they studied, all the healthcare workers, none of them tested positive.
Great. Thank you very much. All the speakers, fantastic. And there are more questions for you on the chat and QA. But if you have time, please try and answer them.
Yes,
thanks a lot.
Thank you very much.
Thanks. Take care.
I think we now go to the last session of this part 2 of COVID-19's webinar. And the first speaker is Dr. Firuza Parikh, who is the director of IVF and assisted surgery. And she's going to talk on IVF and the COVID-19 virus. Over to Dr. Firuza Parikh.
Good morning, my friends. Thank you very much for joining us for this very important Just Look webinar. Both infertility and pregnancy are situations that cannot be classified as elective. They definitely need special attention as they involve a very vulnerable population. Both these conditions pose some unique problems that need innovative solutions. The pregnant woman, her partner, their baby, the infertile couple, their caretakers, and society at large become very vulnerable during COVID-19. Similarly, the egg, the sperm, the embryos, the infertile couple, we have to keep in mind the biological clock, the ART procedures, the baby, the partner of the woman, the type of delivery, breastfeeding or not to breastfeed, general considerations, testing, the emotional condition of the couple, and the reproductive cost of aging are all to be considered. Finally, as I wind up my talk, I will also touch upon briefly upon why men are more vulnerable than women in the COVID-19 situation. There were certain considerations that we had to keep in mind when we decided that we should not offer treatment at such time. One was, this was a new beast. We didn't know the effect of this virus on individuals, on couples, on the pregnancy, on the embryo, on the sperm, on the eggs. Also, during such times, if hyperstimulation, ectopic pregnancies, or miscarriage were to occur, we did not know what toll it would take on the woman, the individual, and the couple. Also, PPEs, nursing care, anesthesia, ventilators, and testing were very scarce at that time, and we did not want to have a burden to the hospital in such when things were so precious and commodities were so rare to come by. The other thing that was topmost on our mind was, like the Zika virus, would this cause any problem to the mother and the baby? And since we didn't know the answer to this question, we decided it would be safer not to practice IVF during these trying times. We had to keep in mind the emotional impact that this delay would have on the couple, on the woman. And our team, along with our psychologists and our psychiatry team, spent a lot of time counseling couples as to the way forward. So we need to have the consent of the couple, agreement between the couple and the doctor, And there is a code of conduct that we as a unit performing IVF and the couple have to follow. We had to exclude women from starting the program, those women who were at a high risk of comorbidities such as diabetes, hypertension, and those who were using immunosuppressant therapies. There are guidelines given by ASRM and the European Society for Human Reproduction and Embryology. So we followed all these guidelines. We had to triage patients. We had to screen everybody, including the staff, 2 weeks before we started treatment. And this involved doing SARS-CoV-2 RT-PCR testing for the staff as well as the couple. We follow all the general guidelines of sanitation and adaptation of our procedures to fit in with the standard of care. Now, there is one problem for us. And although we follow all the details laid down in our SOP, the one thing that we have to be very careful of is to have the screening not only for the outside, but also in the laboratory, because we are working in small spaces in the lab, and we have to be very careful of cross-contamination and very careful of the source of our liquid nitrogen. We have to use medical grade liquid nitrogen, medical grade of gases, because we cannot afford for any contamination to come into our laboratory. What we did is we tried to minimize contact of the patient with the staff and minimize all the steps that are required during ovarian stimulation. So we did several dry runs of donning, doffing, what kind of masks are to be worn, what kind of precautions the patients have to be ready with, and how would we disinfect our operating theater. Because in our closed spaces and sterile areas, we cannot use fumigation, and we have to use quaternary ammonium compounds to disinfect the space. So this is a typical consulting room and the reception area during pre-COVID times. And now we have to ensure that our patients have proper appointments in place. We try to discourage attendants coming with the patients, and we, although we would wind up seeing anywhere between 80 and 100 patients a day, we have to now space out our work and only do things which are very, very essential at this point in time. At this point now, in the month of August, we have started with frozen embryo transfers, and in September, depending on the condition, we will be starting with our egg retrieval procedures. We are also exercising now the practice of home collection of semen so that the husband doesn't get exposed coming into the hospital, and there is minimal exposure for the staff. Now, when you have a very busy IVF lab where we do a lot of cycles daily, weekly, monthly, and in a year, this kind of situation is to be avoided. And now we have broken up our team so that there is distancing even in the laboratory. Our laboratory cleaning products are very different from the general products. And in our lab, we use what is called OO-safe, that is a quaternary ammonium compound. And we also use dilute hydrogen peroxide. We have to be very careful of VOCs that are generated in the lab, because this can have an impact on the egg, the sperm, and the embryo. We have been scientific in our approach. We have also realized that we are in a moving target situation where we have to maintain flexibility and the willingness to change. So just to wind up, the last slide is why are men more prone to be affected by COVID? This has to do with our genetics. This has to do with androgen receptors. This has to do with testosterone. The estrogen and progesterone protects women. By and large, women are more careful. They wash their hands more often than men do. Men have a tendency to smoke more and are more exposed to risk-taking behavior. So the genetics of men and women are different. The ACE2 receptor, although present on the X chromosome, helps in a way, because what it does, it converts the angiotensin 2 into a safer angiotensin 127, and this opposes the action of angiotensin 2, giving women more protection. Also, men are less resilient than women, and that also protects women. And progesterone, which is a female hormone, is an immune modulator. So our ultimate aim, ladies and gentlemen, my colleagues and doctors and friends, is to protect the unborn child. And it is the duty of every IVF specialist to make sure that we do no harm to this tiny bundle of joy. I thank you very much for your patient hearing.
Thank you, Firuza, for a very lucid talk. And I think these are peacocks in Kharegat colony during the lockdown.
Yes, Sarosh, I put this up to show you and to show all our viewers that while we are locked in, the animals and birds are out. And these are very trying times, but it also tells us that nature is wise, it's wonderful, and we have to now become one with nature.
And nature has taken advantage of us being indoors.
High time, Sarosh.
Yeah, okay. Thank you very much for a very lucid talk. And you stuck to the time accurately. Thank you again. Now, our next speaker is the Director of Surgical Oncology, Dr. Mehul Bhansali. And he is going to talk on cancer surgeries in COVID times, a different perspective. Is Mehul Bhansali there, please?
Yeah, Dr. Katrak.
Will you put your, fine.
Good afternoon. I think it was supposed to be morning, but it's afternoon now. Thank you, Dr. Katrak and Dr. Shrinivas Desai, for allowing me to speak, and the management to allow me to speak to the large gathering. It is good and bad to be little late in the day, because the good part is that you have to speak less, and the bad part is that already people have spoken so many things in the earlier part, so you have to go on revising your talk. Technically going to speak a little more of my experience and some information which we got in April, and then how we change our information and our confidence in the month of May, and how we started the work at a complete lockdown. And when we were about to resume, maybe the first week of May, we got this information, which was, I think, Dr. Pispati and Nilesh Doctor, that if you do a supramajor surgery in the people who are positive, either pre-operatively or post-operatively, your mortality would be around 24. That means 1 in 4 would probably die, and half of them will have a complete pulmonary complication. At that point of time, I think majority of the patients didn't agree for surgery, because if I had to tell them that 1 of 4 will die, probably they will never agree for surgery. And so were we reluctant to operate. And because of this, all the societies, cancer societies in India, the world over, came out with broad guidelines. And the guidelines said, don't do cancer surgery, which is semi-emergency, only do emergency. Now, cancer surgeries are two types. One is all cancer surgeries are semi-emergencies, because you can't allow them to wait for too long. And some of them are as an emergency, like an obstruction, like a breathing difficulty, like a dysphagia. So the guidelines said only do emergency surgeries. They also said don't do long surgery, don't do microvascular surgeries. Now, in a country like India, normally we have a large tumors in the head and neck areas, which will always require reconstruction. So if I had to operate the patient without reconstruction, technically I can't do a single surgery. Specifically in head and neck surgery, what they said is that do only early surgeries, number 1. Number 2, if the treatment can be given by radiation, go for radiotherapy. Number 3, if you can give neoadjuvant, that means you give chemotherapy to the patient, give them chemotherapy. And don't go for longer and larger surgeries. And if the surgeries require ICU care, don't do that kind of surgery or ventilatory care, because you may require ventilation for your COVID patients. Similarly, even in the breast cancer, they said, give all hormone positive patients, give neoadjuvant treatment or give neoadjuvant chemotherapy and avoid the surgery. Surgery should be done only if the neoadjuvant chemotherapy is not succeeding or patient is intolerable to neoadjuvant chemotherapy. This occurred, and technically speaking, all over Bombay and maybe all over India, people completely stopped surgery for 2.5 months. even in the private sector, even in a sector like a public rural cancer center. This is an article which my friend from Pune published. He works in the rural cancer center. There also, there you can see that surgery became, technically speaking, at a standstill. Maybe 2 or 3 surgeries a week were carried out, even in the rural centers. But you look at the chemotherapy. Now, chemotherapy and radiotherapy technically continued as before. In the end or the beginning of May, we got a little lucky because this information came out from Tata Hospital during the same time that we were sitting at home. From March to April, they operated 494 patients, and of which 75% patients were not tested. Only 117 were tested for COVID. Post-operatively, 6 patients turned out to become positive. The information what we gathered from here is that none of the patients technically had a high mortality. In fact, the mortality rate was same as in the pre-COVID era, and this gave us some confidence to go ahead. My first surgery we started was in the May 13th in Jaslow Hospital, and we did technically a microvascular. We did a head and neck commando with microvascular. Unfortunately, I don't have the slides because we were all worried whether to carry the camera inside and take the phone inside. So that was the first surgery which we did, and we did get confident because technically we were very safe in the theater, and there was a good protocol in the hospital where we could do the surgery. Patient was discharged on day 8 very successfully, and he has also completed his radiotherapy. Now, this was a patient which I saw somewhere in month of May, and I advised him surgery. It's a small tumor. We would have called it a T1 tumor. Unfortunately, being scared and not possible to come and various other reasons, he postponed the surgery. And this is exactly what we got. Now, we all agree that in cancer, if you postpone your surgery by few months, you are going to create a T1 tumor or a first stage tumor to become a second stage tumor. Now, we all know that if you are going to operate at stage 1, probably you'll have a survival of 5 years, about 80%. If you're going to operate them at stage 2, you're going to reduce them to around 60%. So automatically, we are going to make life 20% less for all the people who undergo surgery. This is another patient in the same era. I had a biopsy done about around May time, and the biopsy was doubtful, atypical cells, and so everyone thought, let's wait, why operate him and get him here to the hospital. He's living far up from Mumbai. He waited, and this is exactly what occurred in 2 months' time. A small tumor, like a leukoplakic tumor, technically became invasive tumor, and technically this became squamous cancer when we biopsied him. Fortunately, he's undergone surgery, but we had to do a radical surgery, and he had to have a large microvascular reconstruction. People did say that do not operate breast cancer because a large number of patients will be hormone positive. This lady was hormone positive. He was on double agent hormone therapy from month of Jan. That time there was no skin ulcerations. She waited till the skin ulceration has come. Now she has technically agreed, but of course she's still reluctant because every week she's postponing her surgery, saying that we probably will come next week. Technically now she's agreed to go for surgery. So I think that old guidelines were necessary to base our argument and to create new guidelines. What we are trying to say that we have to treat the patient on their merit. I don't think I will be giving chemotherapy because I don't want to operate. If I can't operate, someone else should operate. So the patient should be operated on their merit. COVID testing is compulsory. We should do a RT-PCR as well as HRCT. That is, as Dr. Pispati and Dr. Nilesh said, we have to keep ourselves safe, our patients safe, our staff safe, so that these testing are necessary. There is some controversy. Some people would say do it and some people would say don't do it. But I think for the safety of all workers, I think we should do the testing. The problem what I'm facing here now is an online consult. Everyone is talking about online consult. But you can't operate a head and neck cancer or a breast cancer without physical consult. So what we have started doing is that we are doing multiple online consults before the patient is ready for surgery. So few consults are online, do the investigations, then they come back, and then we see them before we operate. Again, OT discipline, as Dr. Pispati said, will be very, very necessary. We have to have a different perspective to how we are going to operate. Safe to all, safety first, and then the surgery. Most important thing will be we'll have to decrease the post-op ICU stay. We'll have to decrease the ventilatory support to our patient. So probably we'll have to slightly change our head and neck surgery where normally we keep the patient for 2 or 3 days. We'll have to minimize them. Use the ICU bed for COVID patients in future if they are required. We'll have to do early discharge. And most important thing, I think we'll have to develop is home care, because if I'm going to discharge my patient on day 4, I will need a hospital support or a support from the home care system where patients can be seen at home. They can feel confident to go home early if our home care system will improve. I think a lot to be said. We'll have to improve our home care system, because if this COVID era is going to last for a year and a half, we need to improve our home care where I can discharge very safely and confidently the patient on day 3. So this is what is going to be a new era where I'm going to be ready, or all of us are going to be ready like this. It's easy to see, but very difficult to operate with so many preparations and the mask. There is some amount of hypoxia, and you have to learn how to breathe for 2 hours and 3 hours through the same thing. But we are learning, hospital is learning, and all the people around us are also learning. So in the end, I want to say thank you for attending this meeting, but please do not get worried. I think we have to start working on our patients and treat them as and what they are. Thank you.
Thank you, Mehul. I think you've reiterated the safety precautions that are required in any surgical procedure, whether it's orthopedics, GI, or oncosurgery. The recurring theme is safety of the patient, safety of the operating surgeon, and safety of the operating room staff. I think we now move on to the next speaker, who is the Director of Neurosurgery, Dr. Paresh Doshi, and he will be talking on management of neurosurgical emergencies and functional neurosurgery during COVID. Dr. Paresh Doshi.
Good afternoon, everybody. And thank you, Dr. Katrak and Dr. Shrinivas Desai and the management for giving me this opportunity to present this work. I'm the last speaker on the surgical session, so a lot of things have already been said. So I am going to be more specific towards only COVID-19 and neurosurgery, how it has changed or what we have done during this period. So during the COVID era, or the early part of the COVID part, we all know now that elective surgeries have been stalled or stopped. We have 3 different kinds of surgery: emergency surgery, elective surgery, and what I call it super elective surgery, which are functional neurosurgeries, which can be postponed till years. The emergency surgeries did continue. And so what were the kind of emergency surgeries that we saw during the COVID period, and which we continue to see all the year around, is the brain hemorrhage, trauma. This is a CT scan of extradural hematoma, or cerebral infarct, where there is one artery occlusion and there is a mass effect where you require a decompressive craniectomy. You heard Joy Desai saying that they had a couple of craniectomies that we had to do during this time. And brain tumors. Small brain tumors can be observed, non-malignant brain tumors can be observed, but if brain tumors are of this size, causing mass effect and causing imminent threat to life, we might have to decompress them or operate upon them. If people would think that functional neurosurgery will not see any emergencies, but no, we do have some emergencies, like this particular patient who had reached end of service of his pacemaker, and he required an urgent replacement of his pacemakers, and we continue to tackle this kind of functional neurosurgical emergencies also during this period. So what were the protocols that we adopted during this period? We treated them all as COVID positive patients. We had a chest CT scan to understand the risk associated with this surgery. We used full precautions, what is called level 3 PPE or COVID suit that you keep on seeing on this pictures of my other colleagues. Another important factor that we accounted for in neurosurgery was minimal OT staff. I will share some pictures with you later. Negative pressure OT, because that is considered to be pretty safe. And we have a 17th floor OT, which has been completely converted into a negative pressure OT at Jaslok Hospital. One of the best advantages of this is that this OT is completely isolated from the main OT complex. So the main OT complex remains undisturbed during even the present time when we operate COVID patients. And how did we handle this functional neurosurgical emergency? This was a patient in Gujarat, and unfortunately he could not travel here because there were travel restrictions, and he did need a pacemaker replacement. There was not a neurosurgeon there who could replace the pacemaker because these surgeries are not performed there. I found out a cardiologist in Gujarat and convinced him, because he is used to changing the pacemaker for heart, and he agreed to change this pacemaker for us. And you can see here that this is the wife of the patient writing that I have requested Devan Bhai to have you connected
with his phone so that you can oversee the procedure. And I actually virtually supervised the video surgery through a video call and advised him how to connect the pacemaker and how to test it before he closes the wound. So these are some of the data and statistics that we have during the COVID period about the surgery. And you can see that this was a study done throughout India, pan-India. And what had happened was that initially 30% of the surgeries were emergencies in government hospital, and around 40% surgeries were emergencies in private hospitals, which rose significantly higher in government hospital. In private hospital, it didn't go up so much. So the proportion of the elective to emergency surgeries did change drastically during the COVID period. However, we did not observe this. I took the data out for just look from January to March and April to June. You can see that we had around 80-20 ratio of emergency to elective surgeries, and that continued during this period. Probably one of the reasons is that because we are located in South Bombay, we don't see so many trauma cases like the government hospitals, and probably some of the period of this April to June, we were not as functional. So elective neurosurgery, how do we handle this elective neurosurgery? As I told you, two parts of elective neurosurgery. One is general neurosurgery and second is functional neurosurgery. So what is the protocol for that? Again, this was a result of an anonymized national survey in Neurology India published recently. Most of the neurosurgeons perform single COVID test to operate before they operated a patient. However, we know now that around 30% of this COVID test can be falsely negative. Hence, several surgeons, almost 25% of the surgeons, insisted on 2 COVID negative tests before they took the patient up for surgery in neurosurgery. Some of them were very paranoid, 1 to 2%. They insisted on 3 COVID negative tests, which reduced the false negative to almost 0. However, there are some bold neurosurgeons also, I don't know where they belong to, but they continue to operate without any COVID test. So that was a very paradoxical thing. Let me tell you what happened at Jaslok Hospital. Very early in the game, we realized that this negative COVID test could be an issue, especially if we are operating high risk and long surgeries like neurosurgery and cardiac surgeries or any other surgeries. So what we insisted upon was that we would do a COVID RT-PCR test. If it is negative, we would complement it with a chest CT scan. And once the chest CT scan also confirms that this is an asymptomatic patient with a low risk, with a negative chest CT scan and a negative RT-PCR, he is a patient who can be fit and termed as COVID negative. And we recently analyzed our data for first 150 patients who had undertaken this, and we found that the sensitivity of this was more than 90%. So we were on the right track. And this we had established long back with the Infection Control Committee in early part of April. Coming to functional neurosurgery, there is a movement disorder surgery. These are because some of them you might not know what I mean by functional neurosurgery. So these are the surgeries for movement disorders, psychiatric disorders, epilepsy, chronic pain surgery, and spasticity. Again, many of these diseases you would think that probably are not being treated by surgery, but yes, they are continuously being treating. We have been treating this over the last 20 years. The video on this slide is explaining what a Parkinson disease patient like. Unfortunately, the voice is slightly low, so you might have to concentrate a little bit.
My name is Ashit Dhingra. Disease of Parkinson growing for my father since past about 10 years now. And so we have a family business, and I've always seen him before the operation. In fact, after the disease of Parkinson, I have seen personally that how his activities have reduced to a great extent. So like I said, 7 days a week he used to work earlier, and there came a time where he used to work only 2 to 3 days a week, and in a day he would work hardly for 3 to 4 hours. Then we opted for the operation, and
that was his video before the surgery. Now there will be a video coming for the after the surgery.
Post-operation, we have really seen good results. All of us are very happy with the results, and he's back to his normal routine post the operation, where he can happily go back to work, and he's a workaholic, so that's the best part. Post-operation, it has completely changed, and we really feel happy that we were able to get him operated uh, under Dr. Doshi's observation in Jaslok Hospital. And I must say that we've got our life back. He's got his life back.
So that
My
is
name is
what a Parkinson disease patient has. Now coming back to our data, what we did, this is the statistics of our in percentage, the number of surgeries. These are not the number of surgery, but the percentage of surgeries that we performed in the first first 3 months of the first quarter. And you can see that in May, from 0 in April, obviously hospital was closed. We started slowly escalating the number of elective work. And now we have reached up to 60% of the pre-COVID elective work status. What has happened during this period has been the research and training that has been significantly affected all over. And what we have found was that because we had a cancellation of mostly all meetings all across the board, we also were a casualty to this. We had a very important international meeting on with International Neuromodulation Society planned in October 2020. As you can now see that it has been moved to 2021 November. However, we continued our efforts. We have a neuroradiology meet going more than 25 to 30 years at Jaslok. We meet every Thursday to discuss difficult cases. And this we continued even on Zoom. Functional neurosurgery fellowship, pain fellowship continued to function. A national survey was conducted again to find out how the neurosurgeons spent their time. And they found that more than 50% of the neurosurgeons invested their time either in webinars, writing papers, or improving their knowledge by self-study. We also did our share to continue our education and training. We have started a neuromodulation webinar series of around 7 series in pain and 7 in deep brain stimulation that has been launched yesterday with international faculties to educate students and trainees. So how things have changed, this is a pre-COVID, post-DBS picture. You can see there is a large amount of team work required in these surgeries. Around 14 to 15 people are there in the OT assisting to perform one deep brain stimulation surgery. Unfortunately, we had to change this, and now we have cut down to 50% of the staffing. Most of the staff has been asked to do double the work or different kind of work. They have to wear different hats during the same period, and all of us look like people from Star Wars. We have a very strict protocol. All the person attending the OT have to be within a shield. Not only that, the surgical techniques had to be modified. You can see here, it's very difficult for me to do my work with people having masks and face shields in front of them to avoid touching their area. And also to, at the same time, you can see a small window here. The patient is wearing a face mask here. And the patient is awake in all our surgeries. And we have to be careful that he doesn't contract infection or he doesn't transmit infection. So aerosol generation, we have already spoken to in other surgeries, prolonged surgeries for lasting 6 hours. So PPE suits are very difficult to be worn, and most surgeries are semi-emergency. So increasing the risk for the patient and the surgical team. So what has happened to functional neurosurgery across the country? Jaslok has reached back to the 75% of the pre-COVID status. We have been performing functional neurosurgery. This is again a quarterly data, and we have reached up to 75% pre-COVID levels. Another centers where functional neurosurgery is performed are NIMANS, All India Institute of Sri Chitra. These are the big centers. Some such surgeries are performed in other centers in small numbers. But I took the data from NIMANS. NIMANS has not yet started operating functional neurosurgery because they are overwhelmed with other activities. To end it, we can say a lot of things about ourselves. We can say many things that we feel correct and we are doing right. But the final proof of pudding lies in eating. Unless our patient confirms that, we are now good. And so I took this small video of a patient who has undergone deep brain stimulation surgery recently at Jaslok, and he has been discharged. Please listen to him. Thank you.
I think now we come to the last talk of today's seminar. And it is a rather important subject because Dr. Gopinath Shenoy is going to, he is a doctor with a medical legal background and training, and he is going to talk about the medical legal aspects of management of COVID-19, and he's also going to enlighten us on what are the medical legal aspects of e-consultation, which is nowadays getting to be the rule, and therefore physicians would like to know what are the medical legal implications of e-consultations. Dr. Gopinath Shenoy, please take over.
Well, ladies and gentlemen, the first and the foremost responsibility and duty of mine is to thank the organizers for inviting me over here. It's always been a pleasure to be at Justlook and to speak with respect to addressing the current issues for the doctors of Justlook. Thank you very much for that. With this, I would like to open my talk by saying one thing. There is a lockdown, there's a work at home, work from home policy. Two people are very lucky as a result of this particular policy of the government. The first group are the obstetricians and gynecologists. And I say this is because this lockdown and work from home policy has tremendously increased the MTP rates. Today, the amount of MTPs that are done by the obstetricians and gynecologists is far, far more than what used to happen previous to the lockdown, one. And the second sect that is very lucky in this particular period and in the days ahead are the advocates, because of these COVID problems, the litigation rate has gone up tremendously. Whenever there's a death, there is always a disgruntled relative, and when the disgruntled relative has to pay much more than what he expects, he gets even more angry, and the matter invariably lands into the court. I've been handling a lot of COVID matters in the court of late, and I'm very sorry to say that these matters are not being very much proved or very much decided on the sides of the doctors. That apart, today I'm going to speak on the COVID-19 pandemic and the law, what the law says and what are the laws that affect this particular problem is something I'm going to address you. With this, I go to the first thing. See, there are certain terms that must be understood over here. These are all, I'm giving you the way the law looks at it. Epidemic and pandemic. Epidemic means whenever there's an infection which is seen in a large portion of the society in one country, you say that that country has got an epidemic of so and so disease. Like today, it first started in China. It was an epidemic in China. But the moment the same infection enters into some other continent, it goes into another continent, more than one or two or more than two continents suffer from that particular infection, then the word used is pandemic. Now the word epidemic is used or is noted or declared by the government of that particular country. But when it comes to pandemic, this pandemic is normally declared by WHO, World Health Organization. So this is the difference between the two as to who declares the epidemic and who declares the pandemic. Now, there are certain legalities with respect to whenever there's an epidemic declared or whenever there's a pandemic declared, there are certain legalities involved. And the most important thing that automatically gets involved are the rights. Every individual has a right, but whenever there's a pandemic or an epidemic, the rights of an individual are very much curtailed. So also the rights of the society. For example, the society rights are also curtailed in the sense that when the government declares a lockout, it is the society's right that is being curtailed. When the government says, well, you are going to be quarantined, well, it's going to be the society's right that is going to be hampered. So epidemic and pandemic always involves the rights of an individual and the rights of the society. Now, when this particular epidemic was declared in India, the only act that was made applicable the first act that was made applicable to the people was the Epidemic Diseases Act of 1897. This is a very old act and it was rarely used. The last it was used during the Spanish flu, that's what I've been told. But of course, I was not there at that point of time. But after that, this particular act, this particular act has been promulgated once again and has been very strictly complied with during this particular epidemic. Along with this epidemic act that was proclaimed, there was another act that came into force, and that was the Disaster Management Act. Because whenever there is a disaster of any nature, may it be floods, may it be an earthquake, this particular Disaster Management Act gets promulgated, comes into force. And here also, the Disaster Management Act came subsequently. In Maharashtra, the Essential Services Maintenance Act came into action. And what is very interesting is the administrators, the government also brought another act into force, and that is the Maharashtra Nursing Home Amendment Act of 2006. This was done basically to see that all the hospitals in the state of Maharashtra that are governed by this particular act, and mind you, every hospital in the state is governed by this particular act. So the government said that if at all this Bombay, it was formerly known as Bombay Nursing Homes Act, Registration Act, if this act is applicable to you, then all the things that follow will also become applicable to you. And of course, there were many hospitals that were run as trusts, and they were governed by a different kind of a law. So what the government did so as to bring about uniform application of all the notifications that followed was they brought the Bombay Public Trust Act also into force. And now what happens is, in all these acts, there is one thing that is common. And that is especially in the first three acts, that is the government is bestowed with unlimited powers to issue notifications. And these notifications automatically get the force of law. Normally, when you want to make a law that is applicable to the society as large, to the general public, then there is a particular procedure in which that law is made, and it takes time for that procedure to be followed. But if at all there are notifications can be promulgated, can be drafted and brought into force overnight. And these powers to bring about notification is given by these above first three acts. And the government use the powers by which they can issue the notifications by the powers vested in them by the first three acts. And these notifications were therefore made applicable to everybody, including all hospitals that are governed or that are registered under the Nursing Home Registration Act as well as the Public Trust Act. See how nicely it has been done so that everybody comes within the ambit. Now I told you, epidemic and pandemic gives rise to the rights of the person, and these rights are suspended. Now, why is the rights of the person suspended? The law says that whenever there is a state of emergency declared, the rights of all individuals, all institutions automatically get suspended, and whatever rights are available are declared by the government. So there are three kinds of emergencies, remember. One is health emergency. Now this COVID is a health emergency. Second is there is something known as an external emergency. External emergency is when the country goes to war. There is an external emergency. For example, when there was the Indo-Pak war or war with China, there was an external emergency, but for that, the declaration of war has to come up. The way there was a declaration of epidemic was declared by the government, and the moment the epidemic is declared by the government, there is a health emergency. In the same way, whenever there's a war declared, that becomes an external emergency, and that is why whenever the country goes to a war, it is always said India has declared war. So that is the importance of the word declaration of a particular emergency. And the third one is an internal emergency. Well, internal emergency we all are aware of. Internal emergency also has got to be declared, and there is only once this particular thing is declared, internal emergency. Well, I would not like to go into it. But the thing is, whenever there is an emergency declared, the rights of an individual automatically get curtailed. Now I said the rights of an individual. So who are these concerned individuals whose rights are curtailed whenever there is an emergency? The answer is very simple. See, I'm going to restrict myself only to healthcare. The doctor's rights get hampered. The hospital's rights are also curtailed. On the other hand, the patients also have some rights, but their rights are also curtailed in the sense that if at all you are COVID suspect, if at all you are, they home quarantine you. Your right to free traveling here and there automatically gets curtailed, and the rights of the society at large also gets curtailed the moment an emergency is declared. Ours is a healthcare emergency, remember, and that is what the notification has declared. And that notification becomes applicable to all of us, hospitals, doctors, patients, and the society at large. Now, I'll tell you something. How does the law look at a patient during the COVID era? Now, the COVID era is going on. How is it that the law looks at the patient? This is something you have to understand. The law says a person is COVID infected. And when the law says that a particular person is COVID infected, this COVID infection is based on the swab test. When the swab is positive, well, the patient gets branded as a COVID infected patient. The second group, the way the law looks at it is, the law says that this particular patient is a suspect COVID patient. Suspect COVID patient means whenever the patient is symptomatic, but the reports are still not available, the law, tags this patient as a COVID suspect patient. There's a third patient that the law recognizes, and that is patient in the window period. Now, this window period varies from textbooks to textbooks, from authorities to authorities, but by and large, a window period of 5 to 12 days of infection or a contact, 5 to 12 days of the contact is something which is identified by law. So, technically speaking, if you look at the textbooks, if you look at the journals, it says that 2 to 14 days. 2 to 14 days is very difficult, but by and large, the accepted window period today is supposed to be 5 to 12 days of infection of a contact from an infected patient. Then the law says the fourth group is something known as a COVID negative patient. A COVID negative patient is a patient whose swab is negative. Once again, not a single swab, but a swab done once and a swab followed after 14 days, because the incubation period is up to 12 days, remember. So what the law says is that you do a test and after that you repeat the test after around 14 days. And if both the reports are negative, then the patient falls into this category of COVID negative patient. That's another kind of a patient that the law recognizes. That is COVID infected patient, but cured patient. The patient is infected with COVID, COVID is positive. Subsequently, the patient is COVID negative. This particular patient gets branded as a COVID infected but cured. Now, what is the importance of this particular group? The importance of this particular group is that this particular group, they can give their plasma, they can donate their plasma such that their plasma can help another patient who is in dire need of that particular plasma. And lastly, the law recognizes a asymptomatic carrier. Asymptomatic carrier, as we all know, he is not suffering from any symptoms, but if at all he is tested, he becomes definitely can be identified to be a positive patient. Now, it is believed that practically 80% of the patients fall into this particular group. And as far as we doctors are concerned, as far as we lawyers are concerned, who defend the doctors in the court, this particular group becomes a very important group for us, because it helps us, tell the court that it is very much possible that this particular patient was an asymptomatic carrier who subsequently came out to be positive once the patient got admitted to the hospital. So, law recognizes 6 varieties of patients. Now, I tell you, there is something known as duties and there is something known as the rights. Now, when the rights of the citizens have been curtailed because of this COVID infection, there are certain responsibilities given to the state by this particular law. And that law that gives certain responsibility to the state is the directive principles in Article 47 of the Constitution of India. It says the healthcare facilities must be provided by the state to every citizen. So every citizen is entitled to be looked after by the state. It also says that whenever there is an infection of any nature, it becomes the bounden duty of the state to contain the epidemic, to contain the infection. And the state can do anything it wants. And one of the ways in which infection can be contained and restricted from spreading is by the lockdown. And the second important reason, place where where this particular thing comes into action, is disposal of the dead. I will speak about the disposal of the dead a little afterwards. The third thing the law says is that the state must investigate patients. And the law says that maximum investigations must be done. If you see the United States, the identification rate is so high is because a lot of investigations are done. But vice versa, if you see what happened in India, in the initial days, the testing was done restricted only to symptomatic patients. And this was because the tests were in short supply. The state did not tell us that the tests were in short supply, because that would be a negligence on their part, because they are duty bound to provide the test to the doctors, to the citizen at large, but they were not able to do it. In between, they imported certain tests from China. Those tests were also identified to be not functioning properly. There was a chaos because the test was not made available to the society at large, which they were supposed to do. The next problem that the state is duty bound to do is provide PPE kits to all the corona workers. Now, you know something, the doctors working in the public sector, that's the government sector and the municipal sector, are today the most affected, because the kind of PPEs that have been provided to them, and the duty to provide them PPEs is that of the state, was supposed to be not up to the mark. I shouldn't say very bad, but not up to the mark, as a result of which a lot of doctors working in the public sectors got infected. Many of them have also expired. And finally, it is the bounden duty of the state to treat the infected patients. But once again, over here, what has happened is the patients are so many that the public hospitals are today overflowing. The public hospitals are not able to provide the kind of the treatment that is expected, as a result of which a lot of people have overflowed into private sectors. And what the government has done is government has now restricted the private sectors and curtailed their rights. I'll come to it. I'll curtail their rights, as a result of which a lot of load that the government was supposed to shoulder is now being shouldered by the private sector. This also happens with respect to quarantining of the patients. Whenever the patient comes from a COVID infected country, they are given two options. You quarantine in a private setup where you have to pay money, or you quarantine in a public setup where everything will be done free of charge. And invariably, the patients, these travelers, passengers, opt for a private quarantine because the facilities in a public setup is miserable. That all of us know, but that is what is happening. The directive principles, Article 47 of the Constitution, makes it a bounden duty upon the state to look after the patient, look after the patients, look after the citizens, especially when the citizens are sick. Now, I will tell you, I told you in emergency, the rights of an individual are curtailed. And I told you it is the doctors and the hospitals whose rights are curtailed. Now, what are these rights that are curtailed? I will tell you what it is. Now, the notification says that doctors must give compulsory COVID duty. That is, if at all the COVID duty is put upon you, is cast upon you, you are directed to undergo a COVID duty, you cannot refuse it. You have to accept that and do the 14 days or 15 days COVID duty that you are called upon by the government, by the state to do. Now, all of us know that in between there was a consent that the state took from us. Initially, the state gave the consent via emails, but subsequently this particular consent was taken from us through the Maharashtra Medical Council. Now, what is the value of, and all of us have signed it, all of us have given it, we all are aware about it. Now, I want to tell you what is the value of this particular consent that has been taken by the state from all the doctors in the state of Maharashtra. So if you read that particular covering note to the consent, that covering note says, if you don't give this consent, action will be taken against you by the provisions of the Indian Medical Council Act or by the provisions of the Maharashtra Medical Council Act. Now, whenever a consent is signed, this consent has got to be a free consent. By that I mean, this particular consent must be given with a free will, without any coercion or without any force. Now, this particular covering letter that was given along with the consent form for all doctors to fill, there was an element of coercion there. There was an element of threat there. And that is why whenever this question was posed to me, I have told them to give the consent, it really doesn't matter, because this consent will never stand in the court of law, because this particular consent has been taken from you with a threat element attached to it. So consents with threat elements really have got no meaning in the eyes of law. That is what I want to tell you. Now, there is also an exclusion clause with respect to the compulsory COVID duty. And we all are aware, if at all a doctor is suffering from some comorbidity, this particular COVID duty is exempted from. That is the exception. And well, exceptions always prove the rule. If at all you fall into this exempted category, you definitely are not bound to compulsorily do the COVID duty that is expected from all young doctors today. You'll go one step up. Now I told you rights are curtailed, and among the rights, the major people who have lost their rights are two. One is the doctor and one is the healthcare institution. Now the rights of the hospitals are also suspended because of this emergency, and they are suspended by notifications. Now let's see how the law looks at the hospitals. Remember, once the government identified that the number of patients are going to be much more than the capacity of the government hospitals to look after them, the government the state straight away took charge of the beds in private sector hospitals. Initially, there was a request made whether you want to give your facility to the state and turn it into a COVID hospital. But when they found out that not many people wanted to come and give their institutions to the state and convert them to COVID hospitals, the government started putting the whip. The government said that we will take over. And then the government has identified certain hospitals and have called them as designated hospitals. Now, designated hospitals are of three types. What are the three types of, or rather I should say two types. What are the designated hospitals? The first designated hospital is known as a pure COVID hospital. Pure COVID hospital means 100% of the beds are controlled by the state and only COVID patients are admitted there. Only COVID patients are admitted there, and 100% of the beds are controlled by the state, and here all patients are swab positive. Now there's a second group of hospitals, designated hospitals, and that is known as a mixed COVID hospital. Mixed COVID hospitals are those hospitals from the private sector where the government controls 80% of the beds and the 20% of the beds are the management quota. The management controls 20% and the government controls 80%. And here what happens is, in mixed COVID hospitals, what happens, if at all you are a symptomatic patient and if your swab is not done, if at all you are a suspect COVID patient, such patients have a free access to these hospitals. They are treated as a COVID hospital until the swab report comes. And after the swab report comes, they are either put in the COVID infected area or into the non-COVID area, depending upon how the swab reports come. Now here, what is important to know is 80% of these beds are controlled by the state. And when I say that, I mean to say that the charging of this 80% of the beds, is as per the notification given by the state. Now there is a small gray area over here, whether 20% of the beds that are in the management quota, whether they can charge their rack rates. Now if you ask the state, they will say no. But if you ask the private sector hospital administration, they say yes. But well, there is no court ruling on this. And very soon there is going to be a court ruling that's going to come on this, whether the 20% also are governed by the government notification dated 21st of May 2020. And lastly, you have something known as a non-COVID hospital. Non-COVID hospital is, you can get access to these hospitals only if the COVID test is negative. If the COVID test is not done, these hospitals will not admit you. And here what happens is, in these non-COVID hospitals, 100% of the beds are management quota beds. And therefore, entry into these hospitals is possible only if you give the report to the hospital administration saying that I am not COVID. And this is done basically because the patients who have admissions are admitted to these hospitals are non-COVID hospitals. And if at all a COVID patient enters into this hospital, he is likely to infect all the others. Now, this non-COVID hospitals, who gets the status of a non-COVID hospital? Listen to me, non-COVID hospitals, 100 patient management quota, and the notification, price control notification is supposed to be not applicable to them. And hospitals would love to have their institutions into this last category. But normally the state will not permit it. But there are certain institutions that the state permits to be called or to be treated as a non-COVID hospital. And that is, suppose there's an obstetrics and delivery hospital, a pure OBGY hospital, where patients come and deliver. Birthing facilities are there. Basically a birthing hospital. Such patients fall into this particular group. The government puts them into this particular group because if at all there's a COVID infection in a delivery patient, well, a puerperal patient is very much prone to infection, and if at all she gets infected, there's going to be a lot of problems. And secondly, the newborn babies. Newborn babies also can be infected, and that is why there are certain group of hospitals which fall into category 3. OBGY is one. A pure malignancy hospital is 2. If at all there is a transplant facility hospital which deals with pure transplant, this particular hospital falls into this particular category. And of course, finally, if you are very much influential, you can see that your hospital falls into this particular category. I don't want to say something more on this because it's a very sensitive topic. Now let's go to the next thing. I told you certain rights are curtailed, and one of the rights that is curtailed is charging the patients free rack rates. Now see, in a pure COVID hospital, 100% COVID hospital, there is a price notification issued by the state, and this price notification is dated 21st May 2020, wherein the state tells you how much you must charge the patient and how much you must not charge the patient. Well, can they issue such a notification? They are 100% justified in issuing a notification because during this particular era, the emergency era, the state can do anything it wants, but then it has always got to be reasonable. Therefore, the question is, to whom does this notification with respect to curtailing prices become applicable to? And the answer is 100% in all COVID hospitals. Every patient has to be charged by the notification given dated 21st May. In a mixed COVID hospital, they say 80%. 20% still is a gray area, but let's presume 20% being the management quota, the management can charge rack rates. Once again, I'm saying gray area, there is no judicial pronouncement on this. And finally, whether it is applicable to a non-COVID hospital, once again, there is a gray area. People who own non-COVID hospitals, today people who run non-COVID hospitals, they say this particular notification with respect to price control is not applicable to category 3, and that is why people want their hospitals to be in category 3 so that they can charge the rack rates. Let's go one step up. Now, I told you in this COVID era, 2 people are very lucky. One is the obstetrician and gynecologist because the MTP rates have gone up, and very soon the delivery rates is also going to go up. Work from home, lockdown, there are certain fringe benefits or certain problems. Now the other sector who stands to gain by this is the advocate, the litigatory sector, because the litigation now rate has started shooting up, and it is going to shoot up once things become more and more worse. Now, what is this litigation depending upon? What is the litigation concerning with is something I must tell you. And most of the litigation, the commonest of the litigation today is nosocomial infection. Patients say, well, when I entered into the hospital, I was not suffering from COVID, but afterwards in the hospital, I was detected to be COVID positive, and this particular COVID infection was given to me by the hospital, nosocomial infection. This is the commonest allegation made in the court with respect to the litigation that have been filed so far. The second allegations made by the patient in the litigation is that the senior doctors did not visit me. Now, mind you, senior doctors who are more than 65, there's a government notification that they should stay at home. Well, senior doctors always with teleconsultation do help the patients, do help the juniors who are managing the patients. But then the litigation in the courts, they always say, I was totally at the mercy of the junior doctors, and the senior doctors did never come to see me. The third allegations that the patients make in the litigation, or rather I should say the relatives make, because whenever there's a death, invariably there is a litigation, and that is why with so many deaths, with thousands of deaths the litigation rates are going to tremendously boom. That is what I'm trying to tell you all. The third allegations made is that I was not allowed to visit patients. Well, there is a reason why we don't allow to visit patients, and there is also a notification that visit to a patient who is COVID positive has got to be restricted. So invariably what happens? There is a cell phone made available, and it is via the cell phones the patients are able to contact their relatives. If at all, of course, if at all they are on ventilators and all, they cannot do it. We all are aware of it. Now, I want to tell you this because in Uttar Pradesh, there was a notification issued by the government, and that notification said that all the cell phones that are there with the patient who are in the ICUs must be taken away from the patients. Something which is very sad, but then, well, I told you, the state can do whatever it wants because of the healthcare emergency that has been declared by the country. And finally, invariably, this particular allegation is made, and the allegation is I've been charged exorbitantly by the hospital and by the doctors who visited me, and therefore they are bound by the notification of 25th of May, the price control of dated 25th of May, and I've been charged much more than what the price control is. Dr. Katrak, can you hear me? Hello.
Yes, I can hear you.
You had told me 15 minutes and you had told me 2 topics, but I really don't know whether I'll be able to cover the second one. Second one is also very interesting and needs a lot of things to be told for e-consultation. If at all I'm not able to cover e-consultation today, trust me, I promise I will take it on some other day. That is something also you must hear me, because there are so many nice things to be told there. But then let me finish this today. It looks like I will not be able to take e-consultation, but I will take it on some other day. Now whenever there is a litigation filed against a doctor, now what are the defenses available to the doctor? This is something I have to tell you all. Because see, the thing is, once the patient enters into the hospital, he is presumed to be COVID negative, but he is identified to be COVID positive. And the defense that is available to us is the window period or the incubation period is anywhere around 5 days to 12 days. That's what I told you. But if at all you check the textbooks, the textbooks say that, well, you can become positive post-infection from day 2 to day 14. So this is something which we really need to find out, because if at all the patient after admission to the hospital, if at all he is negative and after 15th day he is positive, then well, you cannot take this defense, because on admission when he is negative, subsequently he is positive, it is a high possibility that he's picked up the infection during the hospital stay, save and except if at all he is a asymptomatic carrier. Asymptomatic carrier is a very good defense that we have got. What is the second defense that is available to us? The second defense that is available to the doctors is the burden of proof. What do you mean by the burden of proof? Burden of proof is a legal terminology, and the word burden of proof means the person who makes a particular allegation, the burden is on him to prove that allegation. Now, if at all the patient says, I picked up the infection in a particular hospital, then the law says that the burden is on you to tell the court how you say that you picked it up from a particular hospital. Now, I am telling you, proving this becomes very difficult. So burden of proof, the moment it is cast on the person who makes that allegation, that is the relatives of the patient, it becomes very difficult to prove in the court of law. So that is one of the safety features that we have got. This is one particular defense I have always used in the court, and I have got away with it. And lastly, a good defense as far as we are concerned is, we can always say that the patient was an asymptomatic carrier. Well, we really don't know whether he was positive or negative. Whenever there's a doubt, the benefit of doubt is always given to the person who is the accused person. And when the medical fraternity is accused of negligence, accused of giving nosocomial infection to the patient, and whenever there's a doubt created in the minds of the court, the benefit of doubt is always given to the person who is accused of the allegations. So we always get the benefit of doubt, and asymptomatic carrier is a very good defense that is available. Now, what is the defense that is available to the doctors and the hospitals? This is one of the best defenses, and I've always got away with it. I've always got my doctors and the hospitals out. Now, I told you that the Epidemic Disease Act 1987 is in force today. And in this particular act, there is one section, which is section 4, that gives a protection to all the healthcare workers and the healthcare administrators. So when I say administrators, I say it is the state. Whenever a notification is given by the state, and if at all there are certain lacunae in the notification, the state is protected. I told you there was a covering note given to the consent saying that you have to give me this consent, and there were certain problems. There was an element of force. There was an element of force in that. There was a threat in that. Now, can you sue the person who gave that, issued that particular letter? The answer is no, because he gets the protection of section 4 of the Epidemic Act. So also the doctors and so also the institutions get the protection of this particular section 4 of the Epidemic Act. What does it say? It says, section 4 says, protection to persons acting under the Act. That means acting under the Epidemic Disease Act. No suit or other legal proceedings shall lie against any person. The word is any person, for anything done or in good faith intended to be done under this Act. So this particular section very much to our rescue, and this is one section that I've always used in the courts of law, and this section always is used for the benefit of the doctors, and the doctors have come out of litigation. Now, what are the allegations made against the hospital in court cases? The allegations made against the hospital is this particular hospital refused to admit me. And here there was a very nice case that was there. There was a lawyer who had a myocardial infarction, and he went to an institution. And this particular institution said, ours is a non-COVID hospital. I can admit you. He required angiography, SOS angioplasty very badly. I will admit you provided you have a test. And that particular test at that point of time was not routinely available the way it is available today. So the admission was not given to this particular advocate. He went home, and subsequently the next day morning he expired. The issue was whether he should litigate. And the answer was he could not litigate, is because at that point of time, if you wanted an entry into a non-COVID hospital, a swab was mandatory. And this particular swab was not routinely available for every person who asked for it. So this is the allegation. The allegations against the hospital is no beds were made available to the patients, refused to admit the patient in spite of beds being available to the patients. Then the allegations are efforts to prevent nosocomial infection was not adequately taken, because some hospitals, it was identified, they worked without PPE kits. And the allegations made against the hospital is, it is very much possible that your doctor, your staff nurse, your ward boy may be a silent carrier, maybe an asymptomatic carrier, and it is very much possible that he has infected the patient. So every person who is going to come in contact with the patient has got to take all the precautionary measures when he comes in patient contact. And lastly, death certificate is something which I feel I should tell you all. So you have to mention on the death certificate whether the patient is a COVID patient, a non-COVID patient, or a suspected COVID patient. You got to mention on the death certificate. Law requires you to mention on the death certificate whether it's a natural death or an unnatural death. A police NOC is mandatory, otherwise they will not cremate the body. Please tell your patients, relatives to get a police NOC. Now the crematorium must be the closest crematorium from the hospital. You cannot take the body to Thane and cremate there from Mumbai. Closest crematorium. If at all there is nobody who comes forward to take a COVID positive body, it is the police who will cremate the body if relatives are not available, and all bodies must be kept in body bags. After a spray of sodium hypochlorite, disinfection has been done to the bodies. The penalties I will not go in. And finally, if at all there's an emergency, please feel free to call us. I'm always available on these numbers. I will always help you all. This is not a commercial proposition. It is free of charge for all doctors of Jaslok Hospital. Don't hesitate. Help is just a phone call away. With that, ladies and gentlemen, thank you very much.
Thank you, Dr. Shenoy. And I think we are going to have part 3 of this COVID webinars. And I think you can cover the remaining part of your topics in part 3. Okay. Now I think
definitely.
Yeah. Now I'd like to hand over the mic to Dr. Shrinivas Desai for the question answer sessions. but may I request that I think all the three speakers try and answer all the question answers that have been asked to them.
Right.
Shrinivas?
Yeah, thanks, Sarosh. Yeah. Now, as we are slightly behind the schedule, we are going to stick to one question for all the speakers. There are questions. Rest of the questions we will request if you can answer them. The first goes to Mehul. How long should a surgeon wait in cancer-related cases if patient is COVID positive?
I think it should be like any other surgery, about 2 weeks after it becomes negative as a safety wise, because the surgery, if he's just recovering and he's still going to reinfect, then the risk will be high. So as I said, all protocols for any major surgery would also apply for cancer surgery. I don't think that protocol should change at all, because the risk is to the patient in the post-operative period, not otherwise, and to the workers. Whether you are going for general surgery or cancer surgery, the risk will remain the same. What was important that cancer surgery, we are not supposed to want postponing it on the pretext that the patient is in the COVID era. That's all. We want surgery to be done on its merit and not to postpone it.
Thank you. Thank you, Mehul. Now, Firuza, are you there? Because your book has come out, there is a question which is very interesting which has come to you. How frequently should hospital healthcare workers, including doctors and nurses, be tested? Because IPL players plan to be tested daily. Now, so in your point, how do you plan to test them?
Okay. So we follow certain guidelines given by the ASRM and ESHRE, where there is a triage algorithm which is created. For my department, we have created an SOP of about 150 pages. What we do, we have broken up a team into three: Team A, Team B, and Team C. Team C is the standby team, and Team A works 1 week and Team B works another week.
Right.
So all the staff members of Team A who will come on Monday are tested on the previous Saturday. And every patient who is taken into our department for any invasive procedures such as frozen embryo transfer or the OPU, which will be starting shortly, will have a swab test one day, day one of the stimulation, and 2 days before the egg retrieval or 3 days before the embryo transfer. We just had a patient, Shrinivas, last week, whose first COVID test was negative. Testing 10 days later, she was positive on the RT-PCR and we had to cancel a cycle. This is because in our laboratory, we have very little space and we have to have enough exchanges of air. Although we have the HEPA filter and all the VOC stabilizers, we still have to be extremely careful because our kind of fumigation is very different from the general fumigation. So we have broken up a team and we do rigorous testing, both of the staff as well as the patient.
Okay,
well,
good. You got very, yeah, I can say it's a very rigorous. Thank you. Thanks.
Not as rigorous as the IPL players.
Yeah, they're planning. I don't know if it's true, but this man seems to know, and then he's written it down. It's very funny.
Wonderful.
Thanks.
Thank you for the question.
Thanks. And Paresh, there is a question come compliment. Where are Paresh? Are you around?
Yeah.
Yeah. The person is congratulating you for your great work and very impressed with the video you showed. And he has asked two questions. A, whether after the surgery, do you need to keep the patient on the medication? One. And two, as large number of these patients are elderly, are they more exposed to more complications in the COVID era?
Yeah, the rate of complication doesn't change if the patient is COVID negative and he continues to remain in a safe zone, which we have a green zone in the hospital and in the operation theater environment. So the risk remains the same. And yes, we are taking special precautions to ensure, like what Dr. Firuza Parikh mentioned, to isolate them from the common COVID group. And even actually Jaslok Hospital itself takes additional precautions for that. They do have to continue to take medications. The medications will have to be reduced, but they do continue to take some medications, just like the other patients.
Okay, there's one more question for you. Should all relatives of the patient be tested? Admitted patient be tested? Or what if negative tested and they turn out to be positive? It can be can be answered even by Dr. Shrinivas. And how to identify the hospital?
Yeah, so first part I will tell you the protocol that we have, and then Dr. Shrinivas can answer about the indemnity.
Indemnity, that's right.
Correct. So Jaslok Hospital, we have a very strict protocol that all the patient and the relatives, both the people are tested. Only one relative is allowed per patient. Each patient is kept in a single isolated single room, irrespective of the class of admission. The patient's relative is supposed to stay with the patient throughout the period of the patient's hospitalization. He is not allowed to walk out of the room or wander down the floor. Unfortunately, I don't know whether you captured it on the video or not. The patient himself told that my nephew was with me, but he was not allowed to go out of the room or to go down, even to take anything. So Jaslok has made very strict protocol, which has helped us to safeguard. So the patient and the relative are same treated like a patient, and both of them have to be PCR negative. Yeah, Dr. Shinoy, please.
Yeah, what you said is very correct. I'd like to add. See, it's a very simple thing. If a person is suffering from tuberculosis, open tuberculosis, the doctor will always test everybody at home, because it is very much possible that he has infected the others or he has picked up the infection from others. The same rule becomes applicable here also. If at all a person is identified to be COVID positive, all the relatives at home with whom he is staying have got to be compulsorily tested. That goes without saying. And if at all they are negative, they've got to be quarantined, kept away from this particular person. If at all there's one relative allowed to be with the patient, that particular relative is subsequently not allowed to go home. He is always kept with the patient in the hospital. Certain facilities are made available to him as well. Now the question is, if at all this is a norm that is accepted everywhere today, and there's nothing wrong about it. If at all it is not done, maybe the healthcare authorities administration might come back behind you, because this particular patient who is with the COVID positive patient might go out and infect the others in the society. That's a very nice thing that has been done. The last thing that I want to tell you is, when it comes to hospitalization, suspected one room, because now the beds are short, so single seaters are all converted into double seaters now, or multiple seaters now. If at all there are two symptomatic patients, asymptomatic patients, they can be put in the same room. If at all husband wife are infected, they can be put in the same room. If at all they are infected patients, they can be allowed to share a room. And if at all there are non-infected patients, they should be kept separately, and all uninfected patients can be kept in a very different room. So what I want to tell you is, asymptomatic carriers or suspected COVID patients can share a room. A lot of room sharing is now taking place because of the utter shortness of beds.
So there is a very interesting question for you, Dr. Shinoy.
Yeah, go ahead. A little loudly, please.
Yeah, can you hear me? Can you hear me? Yeah. Yes. There is an asymptomatic patient. On checking, he has got antibody positive. Yes. Can he be a plasma donor?
According to me, answer is yes. He can be a plasma donor, because he definitely can fall into the category where the infection was a subclinical infection. The body built up antibodies, and once the antibodies are present, these antibodies can definitely come to the use of somebody else. See, subclinical infection can take place. For example, I have not tested myself. I was in the US for a long time. I came back because my daughter-in-law delivered. I've got a granddaughter. When I came back, I was home quarantined for 15 days. And exactly 2 days after I landed in India, all the international flights were put off. I don't know whether I have come in contact with anybody in the US or whether I've got some sort of a subclinical infection. And if at all I've got some subclinical infection, I am not suffering from any comorbidities. My body fought that infection, and antibodies IgG is now present in me. If at all I am an asymptomatic patient with a good level of IgG, I definitely can donate my plasma. That is my take on this particular question.
Okay. And the last question of the day for the session.
In fact, I think you give us just 1 second.
Yeah.
In fact, the body's resistance in an asymptomatic patient is very good. It has kept them asymptomatic because of the antibodies.
Correct.
The answer is that they should be taken.
Yeah, plasma should be taken. That is what I say.
It's still on.
Dr. Sarosh?
Yeah.
Okay.
When there is a good IgG level present, plasma must be taken for donation.
Okay. Yeah. Good. And then the last question for you, Dr. Shrinivas, of the day today.
Yes.
In guidelines, we can write only list O, that is over-the-counter drugs.
No, that is telemedicine. You are talking about teleconsultation.
Yes. So this is a question. If you don't want to take it now, we can take it next time. Next time.
That's not
fine.
So
Okay, fine.
Guideline O, guideline A, guideline B, and guideline C.
They go into the telemedicine. Okay, fair enough. So we will do it the next time.
That's very interesting.
Yeah, I know. Thank you very much for all the speakers. Phenomenal lectures. Very, very informative. Before I ask Mr. George to say thanks, I want to mention first Parsi New Year to my friend Dr. Katrak. And as we are on the era of people retiring, MS Dhoni has retired, Suresh Raina has retired. Now Dr. Katrak wants to retire from this job of doing the conveyor and the moderation of this CMEs. But of course, in cricket and football and all other sports, people who retire, some will come back also. Now, can I and wish you, Sarosh, Happy New Year, and thank you very much on a Parsi New Year. You agreed to be here so long. I know I can see that cup of hot tea which you are trying to put, which probably has something different, better stuff than hot tea. Yeah, go ahead and have it. George, can I request you to say?
Okay. So, Chairperson, Madam Kanta Masan, CEO, Mr. Jitendra Haryan, moderators, Dr. Joy Desai and Dr. S.M. Katrak, it's my privilege and great joy to extend a vote of thanks to all the panelists and cyber participants of Just Look Hospital's 47th Annual Conclave Webinar Series 2. I would like to thank the esteemed panel of speakers, Dr. Paresh Doshi, Dr. Firuza Parikh, Dr. Hemant Thacker, Dr. Sudeshna Ray, Dr. Indraneel Raut, Dr. Joy Desai, Dr. Mehul Bhansali, Dr. Shrinivas, Dr. Ameet Pispati, and Dr. Nilesh Doctor, who have shared their knowledge on the various topics which is so relevant in COVID times. Last but not the least, I would like to thank Just Look Hospital and Research Center for their 47 years of pioneering work and the lifetime of care, and also providing a platform to all the speakers to share their knowledge with attendees. Also, my heart goes out today. It's heavy, Dr. Katrak, I want to thank you for your service in moderating these sessions for a number of years. Thank you very much, sir. We will miss you in our future webinars and conferences. As Dr. Desai said, you may definitely decide to return, and we would be, there waiting and to welcome you. I once again like to thank the panelists, the participants for taking their time out on Sunday morning to make the webinar a great success. Until we meet again, goodbye, stay safe. Thank you.